And I welcome everyone in the room and everyone joining us on the internet now and perhaps even later on today for joining us today for what is the second hearing of Portfolio Committee number 2's inquiry into the impact of ambulance ramping and access block on the operation of hospital emergency departments in New South Wales. My name's Greg Donnelly and I'm the chair of the committee. I acknowledge the Gadigal people of the Eora Nation, the traditional custodians on the lands on which we are meeting today. I pay my respects to elders past, present and emerging, and also acknowledge the diversity of the Aboriginal peoples and their ongoing cultures and connections to the lands and waters across New South Wales. I also acknowledge and pay my respects to any Aboriginal and Torres Strait Islander people who may be joining us today over the course of the day here in person or over the internet. Today we are hearing from a number of stakeholders, including peak medical bodies and organisations, as well as emergency medicine staff and specialists. We will also be hearing from New South Wales Health and New South Wales Ambulance later this afternoon. While we have many witnesses with us in person, some will be appearing via video conference today. And I thank everyone, whether in person or over the video conferencing arrangement, for making the time available to give evidence to this important inquiry, and we appreciate that you're all very busy individuals. Before we commence, I'd like to make some brief comments about the procedures for today's hearing. Today's hearing is being broadcast live via the Parliament's website. A transcript of today's hearing will be placed on the committee's website when it becomes available. In accordance with the broadcasting guidelines, media representatives who are with us or may be joining us later are reminded that they must take responsibility for what they publish about the committee's proceedings. While parliamentary privilege applies to witnesses giving evidence today, it does not apply to what witnesses say outside of their evidence at the hearing. I therefore urge witnesses to be careful about comments you may make to the media or others after you complete giving your evidence today. Committee hearings are not intended to provide a forum for people to make adverse reflections about others under the protection of parliamentary privilege. In that regard, it's important that witnesses focus on the issues raised by the inquiry's terms of reference and avoid naming individuals unnecessarily. All witnesses have a right to procedural fairness according to the Procedural Fairness Resolution adopted by the Legislative Council in 2018. If witnesses are unable to answer a question today and want more time to respond, they can take a question on notice. Written answers to questions taken on notice are to be provided within 21 days. And finally, if witnesses wish to hand up documents, they should do so through committee secretariat staff. In terms of audibility of the hearing today, I remind both committee members and witnesses to speak into the microphone. As we have a number of witnesses in person and video conference, via video conference, it may be helpful, in fact it is helpful, to identify who the questions are directed to, and when answering, responding to whose question. For those with hearing difficulties who are present in the room today, please note that the room is fitted with induction loops compatible with hearing aid systems that have telecoil receivers. And finally, could everyone please just check that your mobile phones have been switched to silent for the duration of the hearing. So with that formal introduction, can I welcome our first witness, and most welcome Dr. Bonning, who joins us via video conference. Dr. Bonning being the President of the Australian Medical Association New South Wales. Good morning. Thank you, Doctor, for joining us. We know you're very busy. Doctor, we just need to go through the formality of having you either sworn or affirmed to give your evidence this morning. So I'll ask you in this order, please, to identify yourself by your name, your position title in terms of who you're representing today, and swear either an oath or an affirmation, whichever you choose, the words of which should have been provided to you. If not, just raise your hand and we'll make sure you get that. Dr. Bonning.
Dr. Michael Bonning, President of the AMA New South Wales, the Australian Medical Association New South Wales. I solemnly, sincerely and truly declare and affirm that the evidence now about to be given by me shall be the truth, the whole truth, and nothing but the truth.
Thank you very much, Dr. Bonning. Just to confirm with you, we have members from the opposition, the crossbench and the government present today over the course of the hearing. And what we'd like to do is, first of all, offer you an opportunity to make an opening statement and then move to questioning by members to yourself. Can I confirm, and we're grateful for having received it, that the AMA New South Wales, Australian Medical Association New South Wales, has made a submission. It's been processed by the committee secretariat. It's submission number 33. It's been uploaded to the inquiry's webpage and obviously stands as evidence to this inquiry, which we'll be using to deliberate over the preparation of our report and our recommendations. And of course, your oral evidence today will sit to complement what's a very helpful and very useful submission. So we thank you for that. I'll invite you now then, if you'd like to do so, to make an opening statement. And can you just take it as read, Doctor, that the committee members have copies of the submission here and have read it, so there's no need to quote slabs out of it. We do have the material in front of us.
Thank you, Chair. We see ambulance ramping and access block as a consequence of issues related to the overall functioning of the healthcare system, demand, supply and funding for healthcare services, constraints on which existed before the pandemic and have been exacerbated in the last 3 years. We are seeing an increase in demand through our members, but also through working with the hospital system, through a combination of ageing population and a growing prevalence of chronic disease, which is forcing or exceeding supply in terms of both number of beds and having the right staff available to serve those beds, and including in the emergency department, and also in inpatient wards. Barriers to access to primary care, particularly in regional, rural and remote areas, are causing downstream effects on emergency departments, and we know that exit block and the package of patients through hospitals and admitted patients awaiting placement in aged care or NDIS-funded facilities also contribute. What we see is that while the pandemic has exacerbated issues, the pressure on New South Wales healthcare system has increased in the last decade, and those effects have been seen through regular reporting of BHI data by New South Wales Health, but also demonstrated through the actions and research of many of the professional bodies, including the AMA, College for Emergency Medicine, and many other healthcare bodies, that we see that doctors, nurses and other healthcare workers are working far harder, and the system is being maintained by extraordinary efforts, including over the last 2.5 years, by healthcare workers, in light of the fact that funding and support is not yet reaching the levels required to maintain adequate performance. What we see is that 1 in 10 patients left the emergency department, most recently without or before completing treatment from BHI data, and an increase of more than 2/3 compared with pre-pandemic figures. And we know that only 62.8% of patients have their treatment started on time. We know that while there are numerous horror stories arising out of unacceptable waiting times, it is the mundane nature of many waiting times that actually contribute to poorer patient outcomes, and that we know affects the way in which patients see and accept their treatment, and also the way in which hospital staff are able to provide that treatment, because they are often fighting a catch-up game when treatment has not been started at a clinically appropriate time. So I'll let there and hopefully expand on these throughout the rest of the questions from the committee. Thank you, Chair.
Okay, well that's very good. Thank you, Dr. Bonning. Well, I might open with the questioning and share it with my colleague, Honourable Mark Buttigieg. Perhaps on this particular point that you made in your opening statement, I might just draw on this to elucidate a bit further, Doctor. You made some comment about specifically exit block and tied that into matters to do with individuals who have entered the, I'll use the word generic system through aged care or through the NDIS. I'm wondering if you could please elucidate on an explanation of the matter of exit block and your particular observation, or the association's particular observations about the dimensional size of that as a problem or an issue to be dealt with.
So we know that this is across Australia. There are 1,400 patients who are trying to re-enter the NDIS system from hospitals, who are waiting on average 160 days to be discharged from the hospital sector. That was reported earlier this year. What we know is that those patients who we struggle to get out from the hospital are a function of their needs. So their need to set up services for them, whether it be in the disability insurance scheme and their providers, or whether it needs to be the access to aged care beds. We know that the growth of our population over the age of 65 has been one of the significant contributing factors to both what is needed for beds outside of hospital, so aged care places, as well as beds inside hospital, which is people with chronic diseases who need to be managed and then return home. So we know that this contributes to a significant percentage, probably in low single digits, to our ability to manage exit and entry of patients through the hospital. Now, when we talk about managing the hospital, we're not trying, or I don't think anyone is asking for outcomes to be that the hospital runs at 50% capacity. We know, and this is from our learned colleagues at the College for Emergency Medicine, that in fact a target of 90% hospital occupancy allows for a reasonable surge capacity to manage unexpected changes, but also to allow for the capacity to move patients through elective surgery, to allow rapid access to hospital should someone deteriorate in the community. And so that dynamic is best supported by managing patients out and through the system, which involves integration and engagement with the NDIS and aged care sector as well.
Thank you for that answer. And just following on from that, very keen to hear your opinion, association's opinion about what we understand but have observed and seen, and it appears to be demonstrated by the figures, that the reduction in the availability of beds in New South Wales per 1,000 people, particularly over the age of 65, so we're dealing with the older cohort, the senior cohort, is having quite an impact. So you made the point of the impact in your first answer. I'm pressing you further about the reduction specifically in the availability of beds per 1,000 people for that older cohort, that actually is having quite an impact.
What we see is that that availability of beds per 1,000 people aged 65 years and over has halved from the early 1990s to now.
That's the number of, sorry, Doctor, that's the number of beds.
Yes, number of beds per 1,000
yes.
of patients, per 1,000 population aged 65 or over.
The cohort, yep.
When we see that group, we know that the group aged 65 and over is increasing. We've done wonders with modern medicine to improve people's quality of life and longevity. And we know, however, that more and more people live with chronic diseases which affect their ability to live healthy, longer lives, many of which also then, with exacerbations, end up in hospital. To that age 65 years and over is 17.2% of the New South Wales population, and we know that they make up 43.5% of all admissions and 53.2% of admitted bed days in New South Wales. So that group is, and has always been, overrepresented with regards to the use of hospital services. That is a function of ageing. We cannot change that. But what we need to change is the way in which we think about chronic disease management within the spectre of the hospital system and not just primary care. While primary care is a significant and important part of the answer to that question of how do you manage the people in the community who are age 65 or in fact anyone with chronic disease, we also need to think about how the hospital, through rapid access to specialist outpatient clinics, is able to manage and plan the care of individuals to avoid unnecessary or unplanned hospitalisation, which is when we have more of a struggle with returning the person to health in a way that means they can live back in the community. So while the bed days, Chair, are very important and the accessibility of those beds are very important for people aged over 65, it is also the systems that sit around it to prevent unplanned hospitalisation that can make the biggest impact on changing the way in which people present to hospital and how we manage them.
Thank you, Doctor. That was a very comprehensive answer. I'll pass now to my colleague, the Honourable Mark Buttigieg.
Thank you, Chair. Doctor, just to kind of tease out that theme a bit, I guess, I mean, reading the submissions, one of the consistent themes that seems to come out is the necessity of looking at it from a holistic point of view in terms of demand and supply, but what are those factors outside the hospital that are creating the demand? And this particular issue you've zeroed in on with regards to the ageing population, obviously that's a function of a society evolving over time to a point where people are living longer because of better medical care and better diets and better living and whatnot. And then on top of that, you've got people in the disability sector as well. So is part of this problem, in essence, that we're, in a budgetary sense, cost shifting from the federal sector to the state sector? In other words, because aged care and NDIS is not adequately funded and administered perhaps to the degree that would be ideal, then the public hospital system is taking up that excess load, which is then affecting occupancies of beds and then affecting the ramping. Is that too simplistic, or is that an accurate assessment?
There has been, and I thank you for the question, there has been a long-term, essentially, essence of cost shifting between federal and states and territories. It's written into the hospital funding agreements, where the Commonwealth Government contributes 45% of the cost of public hospital services and states and territories fund the remaining 55%. So I think even at our starting point, before we get to the NDIS and aged care, we see that states are the majority contributors to fund the services that are required for populations in each state, and that when states try and increase and catch up on the care that needs to be provided, and we hear significant discussion of elective surgery waiting times and other access issues in hospitals, we know that there are annual funding growth caps of 6.5% on compared to the previous year, inclusive of health inflation, which is a disincentive for states to actively go after providing more care, because beyond 6.5% increase, they will be the ones paying for all of the care themselves, rather than in a measured or shared model. When it comes to services outside of the hospital, we see it in through multiple lenses. So it is before the hospital, primary care services, and the accessibility of primary care services are a significant contributor to how people's health is managed prior to any hospitalisation. We also know that with fewer with the long-term capping and under-indexation of the rebate in primary care, so the Medicare benefit schedule, we see fewer medical graduates going into general practice. It's now 13.8% of our workforce, of our graduates entering primary care. We know that that is actually the highly efficient and cost-effective place to manage many of these conditions. Hospitals are fantastic for high quality and high acuity care, but much of the management of chronic disease, which is what our community now faces as its tsunami of care requirements, is in fact best managed in the community, near where the patient lives, and by someone who has a longitudinal relationship with them. When we move beyond and after the hospital, kind of outside the hospital walls, with the NDIS and aged care system, I think what we see is a disconnect between those systems and regular access to the health services that are required. If I posit that many of the people who enter and exit our hospital system from aged care and disability services could be better managed if we could provide services closer to where they are, whether it's into their nursing home, through geriatric care, or geriatricians, through rehab care, through better general practice access, and the same goes for the complex needs of those people with disabilities. We would likely see that many of those patients were less likely to end up in our hospital emergency departments, and therefore start an episode of care in the hospital that is drawn out and not particularly productive for their individual lives, and which also is difficult to manage. Hospitals are generally not set up for the long-term management of the frail elderly, and in actual fact, you want people who have complex needs such as that to be in their own home or in their an environment that is familiar to them, that's better for their long-term care and health. So multifactorial, and certainly many of the elements that you suggest there.
Thank you, Doctor.
Thank you, Mark Buddy. We move now to questioning from Kate Fairman.
Thank you, Chair. Hi, Dr. Bonning. Thanks for coming today. We've got this strange situation where you're actually behind me on the screen, but I have to look forward. But we'll manage. I just wanted to you've got a couple of statistics in your submission, which I have found particularly interesting, and it's about the elective surgery waits. You've got one with, and it's kind of a comparison of 2 years, if you like, or it's not a comparison of the same thing, but the data is from 2 years. So the first one, 2 years apart, the first one is from 2020 to 2021, and your submission states that the poorer outcomes in terms of waiting for elective surgery means that from 2020 to 2021, 3,158 people who were waiting for elective surgery in a public hospital in New South Wales either died or were unable to be contacted, which was up from 2,704 the year before. So that's a difference of just roughly, quickly, almost 500 patients. But in the previous paragraph, you've actually got a more updated figure, which is at the end of April to June 2022 quarter, there were 18,748 patients on the waiting list ready for surgery who had waited longer than clinically recommended, compared to only 2,037 at the end of the January to March quarter in 2020. So sorry, that was a lot of statistics, but if you put those two together, doesn't that seem to imply that the next time we get that data for who died waiting for elective surgery, it's going to be extraordinary in terms of the increase of people who have died because they have waited longer than is clinically recommended?
With much of, thank you, with much of that waiting beyond clinically relevant timeframes, we recognise that for many people's elective surgery, that will cause disability, pain, impact the ability to impact their ability to work. It is, until we see the data, while I can agree with you that those statistics may well see an increase in those people who might have died or have been unable to be contacted while waiting for their surgery, it's very hard to put a figure on who those patients are and what is going to happen to them. What we know is that anyone waiting, 18,000 people waiting for elective surgery longer than is clinically indicated, we have clinical indicated timeframes for a reason. That is because that is when we know that we should have a specific time frame that meets the needs of the patients to actually be clear about what their health outcomes should be. And we know that when patients know those outcome timeframes, and then we aren't meeting those outcome timeframes, that is actually quite detrimental to both their physical and also their mental health, because they know that if we leave them for longer than they should, that's distressing and quite unpredictable for their life and clinical outcomes. So again, I think as we have done in the submission, we have to wait for verifiable data, but certainly the implication is that waiting longer for health access leads to poorer outcomes, including death.
Yes, I think you're being very diplomatic there, Doctor. It is a huge increase from 2,037 to 18,748 patients waiting for elective surgery. So what is that, a six-fold increase or something? So if not more, actually. So that can't be good. That's not a good indicator, is it?
So while it is a nine-fold increase there, it's not we don't know whether that would result in a nine-fold increase in the number of people having died waiting. And so I think I'm going to keep my clinician scientist hat on for a sec and sit on the side of I want to wait for evidence, but I have to agree with the fact that waiting longer leads to poorer outcomes, and we know from across the board that is not just death, that is poorer outcomes for someone who then lives, has their surgery and lives, and is now disabled, is now in chronic pain, is now unable to work. So it has a significant detriment and drawdown on our ability to provide healthcare, because many of those patients will now require more ongoing healthcare than they would have required otherwise.
Okay, thank you. That's clear. So we've got the New South Wales Health is appearing this afternoon, and their submission talks about how they're trying to address all of this, of course. What measures are you seeing that they're putting in place that are effective to deal with this backlog of elective surgery, if any? And how many years do you see a light at the end of the tunnel? Is there a plan to have dealt with, a significant portion of this, hopefully, for example, by 2 years, by 3 years, by 4 years? Does the AMA have a clear idea of that? Have you been discussing with New South Wales Health what that looks like?
So we have been, and I think I'll split my answer into two parts. The first is the ability of our system to ramp up significantly with regards to elective surgery is hampered by workforce and the ability to attract and retain workforce into the state public health system. I will provide more information in addition to what has already been provided in our submission on notice, if that is okay with you.
Thank you, Doctor.
What we see with regards to the plan from New South Wales Health with regards to elective surgery, however, is while there is a commitment to a plan, we have seen that at most turns over any years, this ability to reduce significantly its elective surgery time has been hampered or had hurdles that are completely recognisable and plannable for. So, such as the winter surge of respiratory illnesses that often limits our access to beds for post-operative patients, meaning that we cancel surgeries on the day. The access and pay environment for surgeons, anaesthetists and other health staff, especially in rural and regional areas, means that many are taking or making less of their workload in the public, or doing less of their workload in the public and more in the private. So there is a distinct difference in access between those two areas, especially in places where there is a thinner market, such as smaller regional and rural areas. And even beyond that, we know that with significant increases in funding, it also can't make the system run harder unless you put in place the ability to ensure that workforce is not just appropriately compensated, but given that plan well in advance, and it includes all of the parts of the pipeline. So all of the way from outpatient appointments, where we see a significant hidden waiting list, so people who are waiting to get on the waiting list for their elective surgery, all the way through their ability to then be seen, multiple times in clinic prior to their surgery, including the anaesthetic clinic for those people, chronic diseases that means that they need special care for their anaesthetic or post-anaesthetic care, and then their discharge and rehab.
Okay.
So there are a number of components to that.
Thank you.
We will provide more information.
Thank you. Great. I've got just a couple of minutes left. So I just wanted to just get your thoughts on, again, in your submission, you mention the extraordinary length of time that NDIS patients are spending in hospitals waiting for assessments, waiting for specialist disability accommodation. The average participant waits 196 days for their request to be fully considered. What are your thoughts about ways in which they can be addressed? And just going to potentially a federal issue at the moment, surely additional funding to ensure that we have enough specialist disability accommodation is much more needed now than tax cuts for the wealthy.
I think we'll all, as a healthcare provider, I'll always say that the most important thing is how we take care of those people in our community who are less able to take care of themselves. And so having access to appropriate disability support services, accommodation, the care providers in the community, and focusing very specifically on that pathway from needing to discharge out to the community. It would seem, as an observer and someone who is not acutely involved in that part of the sector, that is an extraordinary amount of time, and that most services, if they were being provided at the relevant level, should not take 196 days to be able to be provided. What we say is that it's a complex team requirement and we need to train that workforce, but we also need to deploy that workforce into the right environments. I note that most of our rehab services are hospital-based, and that providing for and developing community rehab services so that patients or those with disabilities might live in the community but have easy access to rehabilitation services rather than staying in hospital where the rehabilitation services are, would be a better use of community funding and resourcing, and better for the individuals involved.
Thank you.
Thank you, Kate. Thank you, Doctor. We'll move questioning now to the government. Please, Honourable Aileen McDonald.
Thank you, Dr. Bunning. I have in your the AMA submission, you've got 6 recommendations. If I can just turn to the first 2 with regard to the federal government contribution. I was just wondering, was the New South Wales government can advocate for that as well? What steps has AMA made towards advocating for an increase in that funding and the removal of the annual growth cap?
This has been a clear and one of our most prominent campaigns over the last few years. We mainly because we have seen that the 50-50 funding split between state and federal has been very effective in recognising that all of government, Commonwealth and state levels, is responsible for all of people wherever they happen to live, and that those individuals should be supported by both those governments to an equal amount. We have run a significant campaign called Clear the Hospital Logjam, which is exactly about this issue. It's about access block, it's about access to elective surgery, and it has been front and centre with our dealings with both Minister Hunt and our Minister Butler. With regards to this, it's also on a state level with Minister Hazzard that we've been very clear that that is one of the key underpinning facilitators of what will actually drive better outcomes. Because if hospitals and states are penalised for wanting to deliver more care that is effective, timely and appropriate, then what we see is the outcome we see today, which is growing lists of people who are waiting for access to care or access to waiting lists, or even the hidden waiting lists of getting on at the start point, because we don't have enough public outpatient clinics that see those patients who are able to, who need our help. And what we know is that in the acute care sector, there are many people who will wait far too long because our hospitals and health systems need to wait until next funding year to bring them in and actually take care of their issues. And that contributes to some of the backlog that we see alongside just overall demand increase. So we want to fund performance improvement, not defund or disincentivise for when people go over what we would say is a normal funding cap.
Thank you, Dr. Bonning. It's Scott Farlow here from the government. Thank you for your submission. Just going through it now, I think very much what you're saying is that there are a lot of factors that are playing into the issues that we're seeing when it comes to ambulance ramping and the pressures in our hospital, but the primary issue is the non-urgent presentations that are occurring in our hospitals. And that is effectively a symptom of the lack of GPs who are coming into the system, and particularly we're seeing that pronounced in rural and regional communities. Is that correct?
That's one of the significant causes, yes.
And as we've gone through in terms of the funding models and that exist in that space as well, what are you seeing in terms of attracting GPs into those positions in the primary care market? Are there initiatives that are underway at the moment that are seeing an increase or potentially could see an increase, particularly in rural and regional communities?
We think especially in rural, regional communities, you get more value out of the practitioners that you have in your system there by engaging them in the sector and in their private rooms. Models such as what's been done in Murrumbidgee, which is about single employer for trainees, has been met favourably or been seen favourably by those trainees who are going there. We also know that models that have done in other states, such as Queensland, have been effective in some of those environments, though what they do is pull the majority of the care provision into the hospital sector in rural and regional, rather than keeping some of it or the majority of it in the primary care sector. And that's been both a solution, but it also has with it its inherent costs and concerns about how you staff effective primary care in the community alongside effective hospital-based care for more emergent needs in rural and regional environments. I was in Armidale and Tamworth last week on this same issue and saw models and approaches being piloted which go all the way from teaching through university through to the training and then support for primary care, so using virtual hospital support for primary care, which we know is being proposed there, has been, some of which has also been, or simple things have been piloted in Far West LHD in New South Wales, and those options I think are valuable to support primary care. We also, while it is not part of this committee's purview, we need to see an increase for the rebate for access to, so for the Medicare rebate for access to primary care services, because there are many patients who avoid healthcare because they are unable to afford it. And we know that those people will then end up in emergency departments with unplanned and deteriorating health that requires more significant healthcare interventions. So there's some models that have been worked in rural and regional areas. What we also saw was a significant improvement from the Western Sydney Local Health District, their integrated care program, which has been part of our submission, and looked at rapid access clinics for both GPs and the emergency department to move patients rather than into a hospital bed or rather than missing the opportunity to intervene early. It was rather than wait weeks or months for an outpatient appointment, something could be moved in there very quickly. It also recognises that in areas where the community is more culturally and linguistically diverse, that we need more people to help individuals navigate care. We need people at the community level helping to inform better health behaviours, including the seeking of care. Many people who have less familiarity with our Australian healthcare system may well wait rather than seek care early, and that can mean that they have poorer health outcomes. So there's a number of models, some of which are in the submission. We will also take your question on notice, in addition to provide some other models that are available and that the committee can consider in their own time.
Thank you very much, Dr. Bonning. And Dr. Bonning, just one last question from me. With respect to New South Wales' position compared to other states in particular, your diagram that you've included in your submission on figure 1 shows the number of approved available public hospital beds per 1,000 population aged 65 and over for all states and territories. maybe on notice, would you be able to take it on notice, and provide those figures on a state-by-state basis to see how New South Wales compares? But just generally, in seeing in the position, particularly with the primary care space and GPs, just interested on your reflections on New South Wales's performance compared to other states, and whether, from your position, the New South Wales system is doing much of the heavy lifting, in a sense, to compensate for the gap that exists in primary care access.
Well, I think there are two important parts to that. There is a gap in primary care access that's being driven by the workforce. We need to include and engage more doctors in the primary care workforce through training, but also through the subsequent job that they end up taking on after their fellowship training. We see that many of the patients who go to emergency would have reason to believe being managed in primary care, and that access to care services throughout the day needs to be managed. And I want to be very clear that the provision of urgent care services in the community, so rather than urgent care centres, is about strengthening primary care and ensuring that what we have in the community is the ability for those people who would otherwise end up in emergency to have access to a clinician who knows them or a practice that knows them and is then able to intervene at a time which is clinically relevant. Because the ability of the hospital to manage a patient with a what would have been a UTI yesterday but is now a kidney infection today means that we should be, the primary care should be at the forefront of those reforms. I think secondly, there as well, we have to link up that integrated pathway. So there are patients who are too complex for primary care, not yet sick enough for the emergency department, and too poor for a private specialist. They need access to public outpatients. Public outpatients is a significant benefit to the community, but it also means that we have a better understanding of where the healthcare needs are in our community, because they are actually seen by our hospital system. In that regard, those patients will often then be handed back to primary care and managed successfully without needing to end up in our emergency departments. If I might make one last comment, which is primary care is struggling, and you have recognised that through our submission and through the submissions of many others in your own experience. If in New South Wales we add payroll tax concerns to what is already going on in the very tight financial circumstances for primary care, we add another disincentive for people to run practices, for people to work in primary care, and we need to be forthright about the fact that this is a general practice. Primary care is an incredible public service that delivers high efficiency, low cost care, and that pulling money out of that by way of payroll tax, a tax on primary care would be a massive disincentive, but also potentially a massive disaster for primary care in New South Wales. And that is on the horizon, and something that we as a professional body see as a major potential impact for a system that is already under a lot of stress.
Thank you, Doctor.
I know the Honourable Lou Amata has a question, but Lou, we're actually over by about 5 minutes already. Would it be all right if you put your question on notice, and with the next round, you be the first questioner for the government? Is that okay?
Yeah, that's fine, Chair. No problem at all. Thank you for that.
Okay, thank you. Well, on that note, can I thank you very much, Doctor? I have to say your responses have been very comprehensive to each and every one of the questions, and provides us now with much additional information which will sit very nicely with your submission on behalf of the organisation. So Thank you very much, and thank the AMA New South Wales for all the great work it does. Thank you very much.
Thank you very much, Chair. Thank you, members, for having us, for having the AMA today.
Appreciate it.
Appreciate it.
Okay, well, we'll conclude that first witness, and we'll move straight on to our next tranche of witnesses, and the Secretariat will help guide people to the tables.
Just in the main place, but please come on up and we'll figure out who's sitting where. Sorry, it's all.
Thank you. Hello. Other side, here we go. Thank you. Thanks.
Thank you very much for all that quick switch over. Appreciate that. Well, welcome to you all for the next part of the hearing this morning. I need to get to the formalities first, which is to have each of you sworn or affirmed to provide your evidence, which will involve you stating your name, your position title, if you're representing an organisation today, and I think you all are, but if one is not and speaking on behalf of themselves, should identify that as the case. And then swear either an oath or an affirmation, whichever you prefer, the words of which you should have there with you. If not, for some reason, put your hand up and we'll provide them to you. So move from left to right, that might be easiest for me. So Dr. Pan.
Yeah, thank you. My name is Dr. Jonathan Pam, and I'm the Chair of the Society of Hospital Pharmacists of Australia, New South Wales Branch Committee. I solemnly and sincerely and truly declare and affirm that the evidence now about to be given by me shall be the truth, the whole truth, and nothing but the truth.
Thank you very much. And Mr. Yick, have I pronounced that correctly?
Yes, you have, Chair.
Thank you.
My name is Jerry Yick. I'm the Head of Policy and Advocacy at the Society of Hospital Pharmacists of Australia. I solemnly, sincerely and truly declare and affirm that the evidence now about to be given by me shall be the truth, the whole truth, and nothing but the truth.
Thank you, Mr. Yick. Dr. Swinburne.
My name is Dr. Elizabeth Swinburne. I'm a counsellor on ASMOF. I solemnly, sincerely and truly declare and affirm that the evidence now about to be given by me shall be the truth, the whole truth, and nothing but the truth.
Thank you very much. And Dr. Sarah, welcome back. We've had you at other hearings before.
Thank you, Chair.
Welcome.
Yes. We make it a habit of trying to make submissions to
We're happy to have you.
government policy. Thank you. Yes, my name is Dr. Tony Sarah. I'm the President of ASMOF New South Wales, and I swear that the evidence now about to be given by me should be the truth, the whole truth, and nothing but the truth, so help me God.
Thank you very much. Just to confirm for both respective organisations, starting with ASMOF, first, your submission's been received, processed, and stands as submission number 29 to the inquiry, and it provides valuable background for the questioning that we'll have later after opening statements. Take the submission as read, so in terms of the opening statement we'll come to in a moment, you don't need to quote slabs out of this. You can formulate some general observations. And with respect to the Society of Hospital Pharmacists of Australia, equally, thank you very much for your submission. Been received, processed, stands as submission number 15 to the inquiry and has been uploaded on the inquiry's web page. So thank you. Well, we'll start perhaps where we're just left with the Society. Will it be you, Doctor, or Mr. Yock making the opening statement?
I'll make the opening statement.
Thank you very much, Doctor. Please proceed.
Thank you. So good morning, Chair, Deputy Chair, members of the Portfolio Committee. SHPA is a membership organisation representing 6,000 hospital pharmacists and colleagues. With respect to ED overcrowding and ramping, hospital pharmacists can ease up capacity in emergency departments in multiple ways. One, by taking a timely and accurate medication history as part of the admission process to facilitate faster admission to inpatient wards. Two, to identify medication-related presentations and resolve these issues on the ED, preventing the need for the patient to be admitted. And three, supplying discharge medicines to discharges from the ED. With respect to access block, our members are telling us that pharmacy is often the hold-up to discharge. This is because there's just not enough pharmacists employed in New South Wales Hospital. New South Wales public hospitals, there are approximately 25% more inpatient beds than Victorian public hospitals. However, there are 25% less hospital pharmacists in New South Wales compared to our Victorian counterparts. Our members tell us that the average time to complete a patient's discharge prescription is between 3 to 4 hours. This delay is due to inadequate pharmacist staffing, in addition to complex patients taking up to 20 medications with complex dosing, medicine changes, and rectifying prescription and prescribing errors before the dispensing process can even begin. Furthermore, our members tell us that patients are often kept in the hospital unnecessarily over the weekend as inpatients, as there are no pharmacy services on the weekend to provide medications. Hence, the underinvestment of pharmacists in New South Wales hospitals has contributed to access block. Our members in New South Wales know their pharmacy departments are the most poorly resourced in Australia, and addressing the workforce gap is key to ensuring pharmacists can do their part to assist with health system capacity, ED overcrowding, bed flow, and access block.
Thank you very much. That's a very concise and to the point opening statement. I'm sure we'll get to some questions which will help elucidate that further. To Asmoff, and listen, would both like to make an opening statement, given that there's specific roles here, I think, between the two?
Yes, Chair. As the President, I will give a sort of a briefer, broader overview, and Dr Swinburne is an emergency physician, so she can give the perspective of our members in
that would be good, and to share between yourself the time. That's fine. Thank you very much.
Thank you, Chair. Thank you for the invitation to ASMOF to make a submission of this hearing. Our union represents about 5,000 medical staff, and access block affects the community, it affects us, it affects our members. Overcrowded emergency departments cause our members significant stress because they cannot look after patients properly. Sometimes they are treating them in corridors. Many emergency departments across New South Wales are currently a safety hazard for patients and for staff. They do not function properly when they're overcrowded. It's just not possible. There's nowhere to put people. People get forgotten, things go wrong. And the literature is quite clear on that. The root cause, as the inquiry has heard many times, is no empty beds in the hospital. So we basically need more beds with staffing, and we need to move patients out that don't need to be in hospital anymore. And there's already been evidence to the inquiry as to the reasons for that: federal-state relations, persons waiting for NDIS funding, persons waiting for nursing home beds. Over the last few months, there have been hundreds of persons in our New South Wales hospitals that shouldn't be there, that could be out in the community, providing an empty bed to put someone into from the emergency department. The issue of hospital occupation utilisation is an important one. Many years ago, we used to aim for 85% occupancy. Many hospitals these days run 100% or greater than 100% occupancy. It becomes impossible to run an efficient system. It's impossible to put patients into beds if they aren't there, if the hospital is overfull. So beds is an important issue. It's not the only solution, but from our perspective, our members in hospitals and emergency departments, it's an important one. So we need doctors and nurses to staff those beds. Staffing of hospital wards is not good at the present time. It's been made worse by COVID. It's been well publicised that our doctors in training, that's the interns, residents and registrars who will treat you when you come to the emergency department, are overworked, underpaid and worried about making mistakes due to fatigue. The number of doctors who report making mistakes due to fatigue has gone up this year from the survey last year. Our doctors in ED and hospitals, they're burnt out, they're leaving the system. We're all working under industrial awards that haven't been updated properly in over 35 years. I was an intern under the Medical Officers Award in 1984. It's essentially the same. We have been unable to negotiate fairer, proper, safer working conditions due to the government's wages cap. So, as a result, work health and safety is not really properly addressed in our workplace. We can safely say it is no longer an attractive option to work in New South Wales. Doctors are leaving the state, or they work as locums and make significantly greater amounts of money and have work-life balance, or they become visiting medical officers. They are paid more and they get better work-life balance. We need to do better for our patients in New South Wales. We need to take care of our doctors who are working in our public hospitals. We will never solve access block unless we the beds, staff, and think about how we run that system. I'll hand over to my colleague, Dr. Liz Swinburne, who is an emergency physician. Thank you, Chair.
Thank you, Dr. Swinburne.
Thank you. Thanks very much for this opportunity. So, obviously, I'm an ASMOF counsellor, but I'm currently working full-time in Royal North Shore Hospital Emergency. Prior to July, I spent 12 months as a medical lead for the virtual hospital, looking after the COVID patients in the home, and for the 12 months prior to that, I was a medical lead for a hospital in the home. So I've got a bit of a broad range there. I also do some work in a private urgent care clinic in Sydney, and do some shifts in a regional centre, and do some work in a remote hospital, which doesn't have any access block, which is very nice.
Just before you go further, can I ask you, Dr. Swinburne, sorry to cut you in.
Yeah.
But, did you have a chance to either see evidence on Wednesday from...
Yeah, I saw some of it, yeah.
Okay, and a chance to read the Hansard? The Hansard has just been published. You may not have. That was the actual record. But anyway, I did
watch quite a few of the submissions on Wednesday.
That's fine. Okay,
yeah,
thank you.
So that's why
that's fine.
I know there was questions about had they worked anywhere else. So
yes, no, thank you very much.
Interstate.
That's good. Yep.
So when this inquiry was announced, ASMOF put together a working group of doctors from across New South Wales hospitals, and the clear agenda was to develop some outcome-based solutions rather than talk all about the impact. We've heard a lot about the impact on staff and patients. So yeah, I have read and listened to a lot of submissions, and while there are some very innovative ideas being discussed, a lot of them aren't going to make a difference to access block. For example, urgent care centres, virtual fracture clinics, they're great, and they would be great for the community, great for patients, but the problem with access block is patients being admitted. So even the urgent, there was a question about urgent patients, or the non-urgent, Cat 4s and 5s, they're not really a big problem for access block. Access block is due to patients who are admitted and there's no beds in the hospital. So it's patients who come who need to be admitted, patients who can't go home because there's nowhere to look after them, and patients who are in hospital and their length of stay is too long. So I just want to mention 4 of the solutions that we think will go a long way to helping address access block. One is having a registered nurse in every aged care facility 24 hours a day, 7 days a week. This was mentioned the other day as an issue. This will improve end-of-life planning. It'll improve access to end-of-life medications because AINs and ENs aren't able to do a lot of things and will automatically send patients to emergency. We need, along these lines too, more hospital outreach facilities, meaning like a rapid response team that goes out and assesses particularly elderly people either in their own home or in their aged care facility. And these have been shown to stop patients coming to hospital, and that's what we need to do. Outpatient clinics are a really great way of preventing admissions. So if there's chest pain clinics, clinics for rapid access neurology or stroke patients, respiratory clinics, where in emergency we can then send patients home knowing they've got an appointment in 2 days to follow up. The alternative is admitting the patient to hospital, and that could be 3 or 4 days. And the other big factor is consistent discharge policies and protocols to reduce patients' length of stay in hospitals. The surgeons are really good at this. They get paid when they operate, so they want to get patients home. They allow nurses or their junior staff to discharge patients. We're finding more and more with VMOs, staff in the hospitals rather than staff specialists, as physicians, they get paid when they see the patient. So there's a financial disincentive to actually getting patients home quicker. So we're all very keen to see some concrete action on solutions that will address the root causes of access block.
Thank you. That's very good as well. So those 2 opening statements augment the very valuable detail on the submission. So we'll move to questioning now. Perhaps if I start, my colleague I think probably have a follow-up question. Just on the matter of returning to a theme that Dr. Sarah commented on about shortage of inpatient beds. Do we know, or can we know, I suppose it's two parts of this question, do we know, can we know how many beds, in inverted commas, we're short in New South Wales? And are there particular locations with respect to those shortages? It's a very general question, and you may need to qualify your answer with respect to specificity in regards to how you answer it. But this issue of bed shortages for inpatients.
It's a difficult question. I actually got involved with bed number planning when I was a young doctor. And for efficiency reasons and to reduce costs, governments around the world have been reducing the number of inpatient beds per 1,000 population. But what's been happening over the last 5, 10, 15, 20 years is with the ageing of the population, we need more beds for those more elderly patients. I'm 70, so I'm one of those cohorts, a little bit naked self-interest there, Chair.
I've got a bit of self-interest.
Thank you. I'm not an expert in bed planning these days, but I think Michael Bonning talked about the numbers that are there. I would struggle to give factual answer to that other than to say my sense is that driving down costs and driving down bed numbers, we've gone too far. So the ageing of the population, increased use of technology, increased desire to take care of people. I suspect that we don't have enough beds. And I think that's been shown by the COVID epidemic. Even before COVID, we were struggling with bed numbers. So when you couple not quite enough bed numbers, increasing drive for cost cutting, and COVID, and the cost shifting between the federal and the states in regard to healthcare, it's very difficult. So I could not give a factual answer.
No. That's helping us understand that. Just listening or observing. Sorry, Doctor. Yes,
just
please.
Make a comment to that too.
Go.
Agree. I don't think we know how many we need, but also with things moving, like with COVID, we thought we need heaps more beds, and we did, but that was managed really well. I mean, the Ministry of Health and State, we actually managed the COVID epidemic extremely well. We pivoted very quickly when things happened. We had set up amazing teams of doctors and nurses who were able to call patients every day, and there would have been so many more come to hospital if that wasn't in place. So if we do everything the same as we do now, we will need more beds. But I think hopefully this is an opportunity to look at other ways of doing things and having more virtual hospitals, allowing access. A lot of GPs do virtual health now. Even, with pharmacy, do we need to have a hospital pharmacist? I know you might not like me saying this, but do we need a hospital pharmacist to do the discharge dispensing in hospital, or should it be sent to a pharmacy and then the medication gets delivered to the patient's home? If, as you say, patients are staying in hospital 6 hours or days waiting for their medication to be dispensed, well, instead of employing more pharmacists, get pharmacists to visit the patients at home and go through their medication at home and check that they're all on the right medication, rather than just doing the same things again. And I would like to think this is an opportunity to try to address some of those things and do things differently.
Colleague, do you have a question on the follow-up?
Thanks, Chair. Just on one of the points I think Dr. Sarah made with regards to the stress and WHS issues in these environments, and we've heard some horrific stories, obviously. Just interested to know, is there a fatigue management policy that's employed in these environments?
There's an award that's significantly out of date. We've had some increases in terms and conditions by policy directive. The federal AMA many years ago did rostering rules, fatigue management things. We basically ignore them. We don't have enough staff. There's no incentive to properly cost the services we provide. The culture has been not to pay overtime. The New South Wales health system is based on the unrostered, unpaid wages theft of the hospital system of young doctors. And that's been well and truly established. Needs cultural change, needs a new award. We need to look at the fatigue management processes. We need more money. We need cultural change. As you're probably aware, ASMOF is suing the state of New South Wales and the Supreme Court about these exact issues.
So, Doctor, just to clarify, New South Wales Health does have a fatigue management policy that hospitals are meant to implement, or is it no?
No.
No.
I'm not aware of one.
So you have this situation where right across industry, these things are standard processes, like, for example, 16 hours in 24, door-to-door, home-to-home, all this sort of business, rest breaks, all the rest of it, and this is not a thing in New South Wales.
It's not in the award. We've got a policy where you should not work longer than 14 hours and you need a 10-hour break between shifts. That came in last year, but until that point in time, there was nothing. So if you're a surgical JMO, RMO, and you need to come at 6 o'clock in the morning to do rounds with the patients before the boss comes, and, theatre goes late at 7, 8, 9 o'clock, well, you go home at 8 o'clock and you come back again at 6 o'clock in the morning, and you'll do that for a term.
Right.
You'll do that for 10 weeks times 5 days, and that's... When I was an intern, I did neurosurgery at Prince Alfred, 7 o'clock ward round in the morning, 7 p.m. ward round at night, and then you went and did your ward work after that. That term was still in existence 2 years ago.
You've got people dealing with people's lives who are working excessive,
Yes.
unbelievable hours and then having to travel home,
Yes.
presumably totally exhausted.
Well, the horror stories have been coming up for a long time of people falling asleep driving home. As a union, and as a union of doctors, we're seriously and significantly concerned. We've been banging the drum about this for years and years and years. It doesn't help patients. Tired staff, fatigued staff make mistakes. The literature is very clear on that. Other states and territories have updated their awards. The state government's provided more money to the salaries and wages budgets. We've been unable to look at the awards in New South Wales for 35 years. And as I said, we took we have one card left in our hand, and that was to sue the state government.
Legal action, yeah.
I'm 70. I want to cease being the president with the legacy of a significantly safer, better award for young doctors. Take care of them so they can take care of the people they want to serve, the people of New South Wales.
Thanks, Doctor.
Thanks, Doctor. Question, Mr. Kate Fairman.
Thanks, Chair. I'll go to the the Society of Hospital Pharmacists of Australia reps first. It's quite extraordinary, really, in your submission. You state that there are 2/3 of emergency departments in New South Wales that don't have a hospital pharmacist over the weekend, and we've heard already during this inquiry just how bad 8 a.m. on a Monday morning is for everybody not being able to be discharged or seen. What's the response by New South Wales Health or the Minister in relation to what I assume you do advocacy and kind of request that policy changes in some ways? Why is there such resistance? Like, what are you getting back from the government when you are telling them that our hospitals need more hospital pharmacists?
Yeah, so what we've been hearing from our directors of pharmacy and hospital pharmacist members in New South Wales who do make requests to their chief executives for more resources. Our understanding is that the chief executives
At the hospital?
At the hospital, that's of the hospital or LHD, are allocated funding for additional staff. Unfortunately, unlike our medical colleagues, pharmacy in New South Wales, which is unlike other states, it falls under the purview of the Chief Allied Health Officer. So when you do have additional funding for pharmacists in New South Wales public hospitals, it's usually you're carving up that money with speech therapists, occupational therapists, and other health professionals. So pharmacy, by that nature, gets a much smaller slice of the pie compared to other states, where pharmacy sits by itself outside of allied health and alongside medical. So I think having that recognition of pharmacy services and the importance of pharmacists under how New South Wales is structured is really, really important, because I think the way that it's currently structured means we're just not getting enough pharmacists. And absolutely no disrespect to my allied health colleagues, but when things go wrong with medicines, you can absolutely cause a patient death. And we have seen that before in New South Wales. Contrast that to, errors in allied health disciplines. You can have really bad things happen to patients as well, but unlikely to result in, patient death. So in saying that, we've heard over COVID in the last few years where there have been additional funding for clinicians due to COVID. Only some of that has trickled down to pharmacy departments. So we know directors of pharmacy have been making bids and requests to their chief executives for more pharmacists. I know in one hospital they asked for to staff vaccination clinics, and for the ramping up of intensive care units, they needed 4 extra pharmacists. They were given 1. And that's a lucky case to even have 1 additional pharmacist. And I think that's actually contributing to a lot of the stress and burnout and fatigue that we've been seeing. That's already existed well before COVID. It's just even worse now with COVID.
Yeah, okay. Another question as well. As a pharmacist's daughter, this is very dear to my heart. Also, you've mentioned that of a model of care implemented at the Sutherland Hospital. Would you mind just telling the committee how that model of care has impacted positively on emergency departments? This is on page. This is after recommendation through above recommended. I can't see the page. I'm sorry.
Yeah. So essentially, at the Sutherland Hospital, what they've invested in there is an emergency medicine pharmacist. And I think my colleague, Dr. Pem, has talked about the benefits that emergency medicine pharmacists bring. So we know from statistics that each year there are 400,000 medication-related presentations to ED, and then additionally 250,000 medication-related hospital admissions onto inpatient wards. So patients come to hospital, come to an ED, and a lot of these medication problems could be, there's shortages of medicines, and Dr. Pettam told me today that according to the Therapeutic Goods Administration, there were 300 medication shortages. So we see this all the time, actually, patients that have run out of the insulin. And what do you do when you run out of insulin? And there's a shortage and the pharmacy's not open, well, you go to ED. We know patients go to ED when they run out of their methadone, run out of their pain medicines. So when there are medication supply issues, absolutely patients end up in ED. So that's where a pharmacist can resolve those medication supply issues. So if they're there purely because of a medication-related issue, be it supply, be it they're experiencing a side effect, a potential drug interaction, the pharmacist can understand what the problem is and resolve it from the ED. So that would actually then save an admission to the ward completely. So in the setting of, say, on the weekend where you don't have a pharmacist, the doctor, who's obviously really busy dealing with a lot of admissions, and the nurse who may not be able to detect a drug interaction or detect an adverse event, they may not be able to understand what the actual problem is and attribute it to a medicine, and then they have to admit that patient to the ward. If you've got a pharmacist there, they can actually find out what the issue is and then resolve it from the ED and get them out of the ED under 4 hours.
Thank you. Thank you very much. Dr. Sarah, I just wanted to go to you. You said at the beginning in your statement, we will never solve access block unless we get the beds and staff. You also said it's no longer an attractive option to work in New South Wales. It's definitely not what the New South Wales government tells us every single time we ask them about this issue. Where are doctors paid more? Where are medical officers paid more? Where are they getting a better work-life balance? Because you suggested that that's what they're kind of going off to do, I assume, in other states.
Yes. Thank you. The award terms and conditions in both Queensland and Victoria mean that a staff specialist there gets approximately $50,000 more to work there.
Say that very loudly in New South Wales at the moment.
$50,000. So that's $50,000 more to go. And young doctors, we hear this anecdotally, instead of going to the bush, instead of setting up practice in New South Wales somewhere, they'll say, look, better staffing, better terms and conditions. I like the sun, or I like the cold of Melbourne, whatever it is, and they go into state.
So the state governments must be offering more incentives, because there's a part of all this, of course, that's this is for working in public hospitals.
This is the awards, yes.
Right. Yeah.
So again, our award hasn't changed. The staff specialist award hasn't changed for 15, 20 years, apart from the 2.5%. And I could go and work in Queensland tomorrow and get an extra $50,000 in my hand to go there. Same in Victoria. It's the same for young doctors. That's the way it is. I brought that to the minister's attention. He said, yes, I understand that young doctors can make more money in other states, and they choose to come here for their training. Because the reality is that if you're looking for a training scheme, you will go wherever you can get a training position, because we don't have enough training positions. But at the end of that process, then you're going to make decisions based on interest, your family, and what you can earn.
Yeah.
And the health budgets in Queensland and in Victoria have more money for terms and conditions. The awards are better. There is true bargaining. There's been true bargaining in Queensland for a very long period of time. Campbell Newman tried to stop that, you may recall, in 2014. But subsequently, he was removed from government, and they went back to proper bargaining. And so the doctors and the government say, what do we need? There's to and fro, there's negotiations. But again, $50,000 more to work in Queensland as a staff specialist than in New South Wales. Similarly for young doctors, the young doctors are not nearly as under the pump as in our state. There's no interest in the health system. Our system is based on wages theft for young doctors. Much less so in Queensland, much less so in Victoria. It was well publicised that the Victorian Labor government provided hundreds of millions of dollars to budgets for two hospitals for young doctors to make their lives better, to make it safer. It's just the way it is.
Thank you. I'm
Do
sorry.
I sound disappointed? Do I sound burnt out about it? Yes, because we are. That's why, as I said, we've taken played the last card in our hand, which is to sue the state government. And we're having mediation in 2 weeks' time to attempt to resolve it, and our answer is a new award. It'll take money, it'll take time, cultural change. We can no longer continue to do this to our young doctors because it flows on to patient care. Patients are harmed as a result.
Thank you.
I'm emotional about it, I apologise.
No, there's no need to apologise. And Doctor, this is an obvious point to make, but just for the record, that's $50,000 per annum.
Per annum, oh yes.
Yeah. No, that's fine. I just...
Net,
sorry.
net of tax.
That's gross. So it'll be after tax. It'll be 25,000. Depending. Yeah.
No, just so that's on the record clearly. Thank you for that. We'll move now to the government members, and the Honourable Lou Amato. Did you have any question, or would like to get the question? Yes, please proceed.
Yes, I do, Chair. No, thank you, Chair. And thank you all for attending today's inquiry. Question is more for Mr. Yick and Dr. Penn. In the submissions, the recommendation was that New South Wales should become a signatory to the Pharmaceutical Reforms Agreement in order to provide sufficient medicine supplies on discharge, reducing reliance on primary care and transition of care, and prevent unnecessary emergency department presentations. I was reading it, I thought that's pretty good. You obviously say patients discharged from public hospitals are currently only supplied 3 to 7 days worth of medication. But can I go a little bit step further and maybe perhaps get your opinion on it? Well, now in other jurisdictions, particularly overseas, pharmacists are allowed to do a lot more than just dispense medication. I know even now pharmacists are doing a bit more, but let's say we can broaden that scope of pharmacists. Would that relieve the pressure? I know I can see the smile there. No, but overseas, a lot of pharmacists do a lot more. But would that relieve some of the pressure, particularly in rural and regional areas, if pharmacists were allowed to do more?
So I'll answer that one. Yeah, absolutely right. Pharmacists have an extensive range of medication history, or medication expertise. They study for 4 years at university, 1 year internship with a very vigorous board exam at the end. So 5 years of training just medicines. And it shows time and time again that when we compare pharmacists even prescribing or charting, in our case, with our medical colleagues, because of our focus on the medicines and our focus on medication safety, we often will pick up 70 to 80% mistakes within the patients that we see in comparison that our physician colleagues have looked at. I think they do a great job, but it just shows the difference in focus, and that our patients right now are much more older, they're more complex than they have ever been before. Our patients on average are on 10 medicines a day, and that, we were just looking on the TGA, there's over 20,000 medicines registered in Australia. There's no way people can stay on top of this unless they're giving it their time and priority. And so as pharmacists, things that we do is just be able to help with that paperwork, get accurate medication histories. A lot of the system assumes things are happening that aren't happening. They assume we know what medicines people are on normally. We don't. And when we take a history, it's often incomplete, inaccurate, and causes even more harms in their admissions. When our pharmacists do a good job taking those histories, a good job charting those medications so that our medical colleagues can actually focus on the diagnosis and treatment, which is what they're trained for and what they're good at. And we want them to focus on that, and we can take away their other issues. As well as assisting with the discharge, we're finding again and again, patients are started new medicines and they're not told much about them. And pharmacists having that expert medication knowledge, we're happy to talk to them and help them have the self-management techniques that they can use to look after themselves, but we just don't have time to talk to them. We don't have time to tell them, and patients are leaving the hospital with new medicines, complex medicines, and they don't know what they're taking. And that's a big problem.
Just going back to your question around, what pharmacists can do more in the scope of practice as well. So this absolutely has been occurring in other jurisdictions. So I know in Victoria and Western Australia, it's quite advanced with what we call partnered pharmacist medication charting. I know it's...
So just repeat that first part of that.
Partnered pharmacist medication charting.
Partnered.
Yeah,
Yep,
partnered,
okay.
yeah. So it's essentially, so at the moment in hospitals where you have junior doctors having to chart patients' medicines on admission, there are a lot of errors involved because they're really, really busy. They're still perhaps new to the hospital. And so a lot of the pharmacists do pick up a lot of prescribing errors when it comes to inpatient charts. So in other states, we've got this model of care where pharmacists are actually doing the charting of the medicine and the doctor just signs it at the end. And this has been proven by or demonstrated by economic evaluations to save, I think, over $700 per admission and greatly reduce the mitigation errors as well. And in Australia, I know the topic of pharmacist prescribing is quite a hot topic at the moment. I would say that partnered pharmacist medication charting in hospitals is the first iteration of pharmacist prescribing in the Australian landscape. And so if we have more pharmacists in New South Wales public hospitals and we expand their scope in the public hospitals and private hospitals to chart medicines, absolutely we'd be seeing faster admissions in EDs and onto the wards. We'd see less prescribing errors, less medication errors, and most importantly, we'd be freeing up doctors and nurses to spend more time with patients at the bedside. And that's actually been one of the major reasons why other states have pursued this, because junior doctors are spending their time getting medication charts charted and then getting a page from the pharmacist to say, hey, there's an error, can you please fix this? So in other states, they've just better utilised the expertise of hospital pharmacists to do that charting, and junior doctors and all doctors in the ED have more time to spend with the patients instead.
I just speak to that too. At North Shore, we have a trial where the hospital pharmacist is doing the prescribing, and it's fantastic. Some of these patients have 10, 15 medications they're on, and for the pharmacist to go through, reconcile with, they ring the pharmacist, the GP, work out exactly what they're taking, because they'll just come in with a big bag, plastic bag full of all these medications, and it is very cost effective and time effective.
That's very helpful to know. The Honourable Lord Amato, you still got follow-up?
Sorry.
Do you have a follow-up question further beyond what you've said? Any other questions?
Yeah, can I just ask one more question?
Yeah.
One of my colleagues has got one, then I'm happy to pass it on.
No, please proceed.
Okay. But do you think there's scope for pharmacists to do more than just dispensing medication? Because I said, I know overseas, a lot of countries, the pharmacists there do a lot more than just dispense medication. But I'm just looking at, I'm not sure about all the amount of studies, I guess, that pharmacists have to do. But is there scope in them for them to do more than just dispense medication, particularly in rural and regional areas and outback communities, to relieve that pressure on the health system?
Yeah, absolutely. So I know we've talked about inpatient charting already, but what pharmacists are expert at is actually undertaking medication review and preventing admissions in all areas, not just regional areas. So, we've heard from AMA already today who've talked about outpatient clinics and outreach services and services into aged care facilities. And so given that we know there's 650,000 admissions or presentations to ED that are medication related, pharmacists, if you have pharmacists that are providing these outreach services or outpatient services, we can absolutely prevent so many of these. We know that approximately half of these are preventable according to data and research. So just for example, in outpatient clinics, if we had pharmacist-led outpatient clinics for stroke patients, for diabetes patients, for transplant patients, for cardiac patients, all these patients in these cohorts take over 5 medicines easily. They have really complex medicines that require dose titration, modification of doses, looking at their lab data to adjust the doses as well. And when any of that goes wrong, those patients end up in ED. Their INR is too high, so they're bleeding out. So all these issues are medication related, and we know these patients end up in ED. So if you do have pharmacists that could be hospital-led outreach services or teams, or they could be federally funded via home medicines reviews or residential medication management reviews, if they can go and see the patient while they're at home or at the aged care facility, detect those areas before they become serious areas, you're able to prevent those admissions to ED and admissions to the ward as well.
Yeah, and I just want to add to that, Lou. The reason I talk about training is that we're already trained to do this, and we already do it. The reason we can't do it is we don't have enough staffing. We're being told, stop talking to them, just get them out of the hospital. Stop making sure that they're okay. Just get them out, get the medicines. So we're being forced to focus on dispensing, not because that's what our primary role is. We do a lot of the clinical services. We make sure that we resolve medication safety issues. A lot of the programs in the hospitals are led by pharmacists, like antimicrobial stewardship is led often by a pharmacist and a doctor. Now we've got opioid stewardship standards. We know high-risk medicines are causing harm and pharmacists can prevent them, but we don't have enough pharmacists. And then we're being told, just get the medicines, just get them out. And that's really stopping us.
I think Dr. Sarah and perhaps Dr. Swinburne as well may have some additional comments to make.
Thank you, Chair. Yes. ASMOF is not opposed to increased skilling and scope of practice of experienced pharmacists in our hospitals. But where Mr. Amato seems to be trying to take us is the Queensland trial of pharmacists prescribing and dispensing, which has been universally condemned by the medical profession. And the newspaper tells us that the Pharmacy Guild, which is essentially a small business owners association, has approached the New South Wales Minister for Health to have a trial that's similar to the Queensland one. There was an article in the Medical Republic in the last week by Holly Payne that demonstrated that all these claims of pharmacists prescribing elsewhere in the world, New Zealand, Canada, the UK, not nearly what the Guild is telling us. So there's a lot of turf war going on here in the Queensland pharmacy prescribing trial, and I don't know that New South Wales should go down that road. ASMOF certainly does not support independent prescribing in community pharmacies. We strongly support our hospital colleagues. They're very competent, they're very experienced, they're very skilled, and an increased scope of practice for them in our hospitals, and more of them would be welcomed. But I don't believe that this inquiry should go down the road of arguing for community pharmacies independently prescribing. I don't perceive it's got a lot to do with ramping in our emergency departments, Chair. Thank you.
I think those...
It had nothing to do, I wasn't aware of the Queensland system or trial up there at all, Dr. Honesty. I've been talking from my family's own experience, having come from overseas, my mother being a nurse overseas, and how the system was over there. I was looking at ways that how we can alleviate the pressures on the system by delivering quality care to patients. That's what I was looking at.
That's okay. Dr. Swinburne, did you have any additional comments, Dr. Stark?
Just one thing that it keeps on coming up is that access to GPs is a big issue with access ramping. And I don't think that's actually the case. A lot of the GPs are wonderful. They are sending a lot of patients to emergency, and they're the ones that need admission. And they are sort of the gatekeepers in a lot of ways. But the access to GPs in the country particularly, if they go to the emergency department instead of going to the GP, and they're sort of GP type patients, they're not contributing to access block. They're going to be seen and they're going to go home. So I think you've just got to be careful when you're looking at what you're talking about, is that access to GPs and GP patients going to ED is not an issue with ramping an access block. And even if the ambulance take them there, we will offload patients into the waiting room if they don't need a bed. So that the ambulance can keep on going. So I think you just got to be careful what this inquiry is for and what solutions you're looking for, because having more GPs is not an issue. Something like the urgent care centre where I work, it provides access to imaging after hours. If you're a GP and you see a lady, say, having a miscarriage at 4 o'clock on a Friday afternoon, they need an ultrasound. You can't get an ultrasound unless you send them to hospital. And even in the hospitals, they're on callback. They're not on site Saturdays, Sundays. So when they're talking about urgent care centres, if there's urgent care centres that actually provide that imaging, CAT scans, ultrasounds, x-rays, pathology, that's going to make a difference to patients going to hospital, but again, or seeking care. But again, it's not an access block particularly problem. They're two different issues.
No, well, point taken. Thank you. Well, let's draw us to the end. I'm sure we could go on, but we do need to move on to our next group of witnesses shortly. But listen, on behalf of the committee, thank you very much. There's been very rich evidence that helps inform this inquiry to be read in conjunction with, obviously, the most helpful submissions you've made, respectively. So thank you very much, and thank you for the great work you do in public hospitals. Thank you.
Thank you.
Okay, we'll have a short break now till probably about 20 past 11. So running about 5 minutes behind, if that's okay. Apologise. I did say 20 past, and normally back on time, and you are. It's 19 past. I've called you short. Well, we'll move now to our next two witnesses, and thank you both gentlemen for coming along to provide evidence to this important inquiry. I'll go through the formality of asking you both individually to identify yourself by name, your position title, and in doing that, to be clear about whether you're representing an organisation in terms of your appearance today, or that you're appearing in your own capacity as an individual, just so that distinction is clear. And then swear either an oath or an affirmation, whichever you prefer, the words of which are for you. If for some reason you don't have them, just raise your hand and we'll provide them to you. We'll then move, once that's done, into opening statements, and then the committee members would appreciate the opportunity to sort of ask you questions arising from your opening statements and also the content of your submission. So are you happy with that approach? Can I just say, listen, we appreciate very much your coming along, and it may well be your first appearance at a parliamentary inquiry. That's okay. This is not a combative exercise. We're not no ambushing and trapping. We're just grateful that you've made the time, and you've had some other very powerful evidence provided by clinicians on Wednesday, which you may be aware of. So we're looking forward to hearing from both of yourselves. So thank you very much, because we know you're very busy in your own right. We'll just move from left to right, just in terms of going through the formalities. So, Associate Professor Mellows, can I invite you, please, to proceed with the formal part?
So just to introduce myself, I'm a senior clinician, senior emergency physician at Nepean Hospital. I hold the role of emergency staff specialist as well as director of emergency medicine training, and my associate professor is a clinical appointment with the Nepean Clinical School at Sydney University. And I'm appearing on my own behalf, not representing an organisation.
Well, thank you, Associate Professor. So can I invite you to take either the oath or the affirmation,
I'll
then,
take
please?
the affirmation now, thank you.
Thank you.
So I solemnly, sincerely and truly declare and affirm that the evidence now about to be given shall be by me, shall be the truth, the whole truth and nothing but the truth.
Thank you very much, Associate Professor. Dr. Vine.
To introduce myself, I'm Kendall Vine. I'm an emergency physician, and I also presenting in a personal capacity.
Thank you. And can I invite you to take either the oath or the affirmation, please?
So I, Kendall Vine, I solemnly, sincerely and truly declare and affirm that the evidence now about to be given by me shall be the truth, the whole truth and nothing but the truth.
Thank you very much. Well, thank you, gentlemen. So We'll now move on to the part where I invite you to make an opening statement. With respect to your submissions that you've made, and we're most grateful for them, they're very comprehensive and detailed. Associate Professor, yours has been received, processed, and stands as submission number 26 to the inquiry, being uploaded to the inquiry's webpage, and obviously forms evidence to our inquiry. And Dr. Bain, yours is submission number 20, so it's been gratefully received. Once again, very comprehensive, and we thank you for that. Processed, uploaded to the inquiry's webpage, and also stands obviously as evidence to the inquiry. So very valuable and important evidence. You can take both the submissions as read, so there's no need to quote large chunks out of this because we've read it and we do have it in front of us. Nevertheless, you can obviously draw on elements that you want to draw to our attention, and that, no doubt, along with other matters you raise in your opening statement, will be the cause of questioning. We have members from the opposition, crossbench, and the government, or from the Legislative Council, and we'll share the questions between ourselves after you've made the opening statement. So, are you okay? We proceed on that basis? Okay, we'll start with Associate Professor. Can I invite you to make your opening statement?
So my apologies in advance if it's a bit long. I haven't really practiced it that much. So first of all, I think this has turned into the access block inquiry. Reading through all of the submissions yesterday, a number of them clearly state that access block and ED overcrowding seems to be the main contributor towards ambulance ramping and the resultant problems this causes. To quote my own submission, ambulance ramping is the symptom and access block and ED overcrowding is the disease. Second of all, I think I've tabled some additional evidence to the inquiry. And this is data from August of this year regarding emergency department performance at Nepean Hospital. The first page is a graph comparing the number of admitted patients that are boarded in the ED at 8 a.m. Compared to ambulance TOC for the day. And you can clearly see that as the number of admitted patients at 8 a.m. increases, ambulance performance and TOC decreases.
I'll just get you, listen, we appreciate, I'm going to have much information presented.
Yes.
So if we just slow down just a little bit. TOC, can you please...
Oh, that's transfer of care. So that's...
No, thank you very much.
Yep.
Mm-hmm. And where was this data from again? Which establishment?
This is from Nepean Hospital.
Nepean, okay, thank you. Please proceed, yep.
Yep, no worries. No, happy to be interrupted.
Yeah, I'll try not to do that if I can avoid it, yep.
The second page contains a table of the mean ED KPIs for August. The significant ones I've highlighted is the number of patients per day on average with length of stays, LOS, greater than 24 hours. There's 4 of those on average per day. The left at own risk, which is a combination of patients who did not wait for any treatment and patients who left before their treatment was completed. That's almost 10%. Cancel admissions, about 5 per day. That's where a patient is admitted, stays in the ED but is not transferred to the ward before they are discharged. They are discharged straight from the ED. Ambulance transfer of care was just over 50% for the month of August, rather than the KPI of 90. And again, the number of admissions and 8 a.m. Waiting for a ward bed was 20. The third page, this becomes a little bit self-serving, is a map of the Sydney hospitals in the Sydney Metropolitan area. Each time figures are released from emergency department performance, the hospitals at the bottom of the list are invariably Westmead, Blacktown, Campbelltown, Liverpool and Nepean hospitals. When you look at this map, I've actually drawn a line north-south through Westmead Hospital, which equates roughly to the geographical and population centre of Sydney. You can see from the map there are twice as many hospitals on the east of this line than there are to the west. Emergency department performance for a hospital must be seen not only as a function of the resources given to the hospital, but related to resources surrounding that hospital. For example, other nearby hospitals, good access to GP services, access to specialist services, and access to regional residential aged care facilities. Lastly, I would like to confirm that on Monday, the 26th of September, there were 9 patients that morning that had been in the ED greater than 24 hours waiting for a ward bed, of which 2 had waited more than 2 days.
What date was that?
That was the 26th of September. On Tuesday, the 4th of October, immediately after the Monday public holiday, there were 8 patients that had been in the ED more than 24 hours waiting for a ward bed, of which 1 had stayed longer than 2 days. As an investigator for the Sydney-wide evidence trial, which looks at out-of-hospital cardiac arrests, I'm also aware of a patient that after suffering a cardiac arrest and being revived by ambulance crews at the scene, stayed in the emergency department for 2 days waiting for a ward bed. That concludes my statement.
Well, thank you very much. It's a very clear, precise and most powerful opening statement. Before I pass over to Dr. Boyne, could I just please go to page 2 of your document about the KPIs?
Yes.
So if we take any one of those, let's take the first one, the presentation.
Yep.
I apologise.
So, did you hear from the other witness in terms of their opening statement as well?
Okay, no, that probably may be a better way to proceed.
Sorry,
just a point of clarification.
Yeah.
No, sorry, I wasn't trying to be disrespectful. I just, but no, no. So, Dr. Byne, why don't you please proceed with your opening statement?
Thank you for the opportunity to speak today. I'm Dr. Kendall Byne. I'm an emergency physician working as a staff specialist at one of Sydney's inner city tertiary referral hospitals and trauma centres. I have an interest in hospital flow. I've authored or co-authored a number of journal papers on flow, and I was part of the Australasian College for Emergency Medicine's working group on access measures. But today I don't speak on behalf of any of the organisations I'm part of. I speak only in a personal capacity. If I can focus your attention on one thing regarding the issues of ambulance ramping and access block, it would be that this is an issue of whole hospital flow. Ambulance ramping is caused by no empty beds in the ED. And there are no empty beds in the ED because there are no empty beds on the wards to move the admitted patients to. You can't fix ambulance ramping or access block without solving the problem of whole hospital occupancy that in New South Wales currently stands at around 100%. I'd like to table a document, present some data showing, like Prof. Mallows, some details of patients' access blocked in the ED where I work, this time from September of 2022. I'd also like to note that every hospital has lists like what I've presented and what Prof. Mallows presents. This is not unique to our hospitals. Every single hospital is a system-wide thing. Firstly, the first 2 pages are all the patients who spend over 24 hours in the ED waiting for a ward bed, including some basic details and the length of stay. The second, as was mentioned by Prof. Mallows in his submission, is the number of admitted patients waiting in the ED at 8 a.m. each day. And that's based on a daily report that we fill out for the ED. The reasons that these patients remain access blocked in the ED is because there are no empty beds on the wards. Unless the solution this inquiry finds provides more empty beds on the wards, then it won't fix the problem. So proposals like patient diversion or use of corridor beds or urgent care centres that don't produce more empty beds on the ward are not going to help. In my submission, I detailed some approaches that were focused on forward flow and how approaches that are not focused on forward flow, like corridor beds, don't solve access block or ambulance ramping, and I offer an alternate approach and solutions based on human factors and on whole hospital occupancy. And I'd be delighted to talk about them further.
Thank you very much, Dr. Byne. Just before we open up to questioning, can I just jump back to the point that I was just seeking clarification earlier, Professor? So on the second page of your helpful document, you've got a table. So if we take, let's just take, for argument's sake, the fourth figure. So it's ETP. Just what does ETP stand for? Just by the way.
Emergency treatment performance, I think, but it's the good old 4-hour rule. Whether you for that particular stat, whether you actually discharge a patient within 4 hours.
Okay. So short stay admissions.
Whether the patient leaves the ED within 4 hours.
Yeah. So that figure's 40.9%. So that is an average figure, is it? I'm trying to understand. So it's a mean figure.
It's a mean figure of the daily performance.
A mean figure. Okay. So that's okay. Okay. And I mean, if everything was going swimmingly, so to speak, in a hypothetical example, in terms of that particular item, what would one hope that would be or expect that would be?
So we're talking about ETP for short stay admissions?
Yeah.
So short stays is run by the ED, and that's where you put out patients that require 6 to 12 hours of workup and treatments, perhaps even overnight. The KPIs, they should have a total treatment time of 24 hours in the short stay. So I think the KPI we have locally at our hospital is about 70%.
Right. Okay. Well, thank you. Thank you for that. Did my colleague want to start, or shall I?
Whatever you're comfortable with, Greg.
Okay. Well, can I ask, and stay with Professor and then to Doctor, this is general in its scope. I think I know part of the answer, but anyway, with respect to the day before evidence, we had some quite senior individuals from the New South Wales health system involved in emergency care and related care give evidence of their own personal experiences in their capacity as individual clinicians. And I don't know whether did you hear any of the reportage about that? Did you even see?
I was actually working on the floor.
No, that's okay.
So
No, that's just helped to inform me. Dr. Byrne, were you aware of any of that evidence?
I read some news articles.
Okay, so no, that's fine. I was just wondering, because if you actually had had the opportunity to see it firsthand and hear it, I was going to raise some particular points, but that's fine. I'll move on. With respect to the matter of beds inside the hospital to receive patients who pass through emergency departments, a key question coming through this inquiry, unsurprisingly, is are there enough beds? It's a generic question. Are there enough beds? And the clarity around the way in which might define the question of sufficient numbers of beds. So there'll be an ability to mitigate that step from the emergency department into the hospital ward per se. Well, I'll ask you first of all, both, say with Professor, do you have a view about whether there are, open quotes, enough beds, close quotes? And then following on from that, how can we be specific about that if we can be specific about that?
So there's a couple of points I wanted to make with respect to that, based on the journeys we've had at Nepean Hospital. The first thing I'll say is we opened a new tower in about 2013, 2014, and that gave us functionally a few more beds. I don't know how many, but it was definitely a significant uptick in the ED available beds. And for about the next 18 months afterwards, ED performance was actually quite good. 2012, 13 not good, 13, 14 very good, because of the new tower opening up a new bed. So there's a clear association between there.
Sorry, is there a consensus on that point? Sorry to interrupt, and I won't do this much, but that improvement,
yes.
Is there a consensus that there's cause and effect there, that in fact the opening of the additional beds was directly facilitative of the...
Yeah, that was the conclusion of the senior clinicians at the hospital.
Okay, thank you.
To the point that when we opened our new tower earlier this year, there were the same clinicians saying, ED performance is going to get it better. Unfortunately, we were disappointed with the actual number of uptick in beds that we got. And I made that point in my submission. The other thing I will make is people do talk about inefficiencies on the ward. And I think I make the point in my submission that hospitals are about as efficient as they can be. And certainly in Nepean, we run a very lean ship. But certainly 2018, when ETP was first introduced as a hard KPI, there were some efficiency improvements we made at the hospital to improve flow, and did get some benefits out of that. So there will be a combination of, are there enough beds? Are we using the beds properly? But I think at the moment at Nepean Hospital, We are functioning about as lean as we can, and we still have 20 admitted patients in the ED waiting for a ward bed at 8 a.m, which sort of suggests that the hospital is 20 beds short.
Okay. Can I invite you, Doctor, just this issue of the linkage, you've got the ramping occurring because of the issues in ED and then the ED not being able to move people in a timely fashion onto the wards, into the hospital.
Yeah, well, I would start by saying yes, that's absolutely. Ambulance are ramping because there's no empty beds in the ED. There's no empty beds in the ED because there's no empty beds on the wards. I do want to stress the idea that it's empty beds that we need, not necessarily, like, we probably need more beds, but mostly we need to make a system that makes sure that there are empty beds on the ward. If you've got a 500-bed hospital and you increase it to a 600-bed hospital, but the system is such that the hospital will always run at 100% capacity, you've now got 600 full beds and still 0 empty beds. You've still got access block, you've still got ambulance ramping. So it actually needs more of a system change to facilitate access block being fixed. The number that tends to be pointed at is we need to be running it closer to 85% occupancy rather than 100% occupancy, and in my submission I provided at least one hospital's evidence that that's around about the right number. How many more beds, I think was one of the other questions you asked. Is there a way to calculate it? That's hard. Again, in my submission, I give a bit of maths to say, look, this is how you would start to go about calculating it. This is a complex system with a lot of knock-on effects. There's always the if you build it, they will come principle, where an empty bed will become a full bed unless the system actually promotes forward flow, not just from ambulance to ED to ward, but also out of the ward.
Discharge.
Discharge. And at the moment, we've got a system that promotes 100% occupancy. I suspect if you did the clever maths, you would find that we are grossly short of beds in all the hospitals. However, I think that if you would just provide those beds, magic them up somehow, you would still have a system that is aimed at 100% capacity. And they would then be, all those beds are now full beds. And we now have back to the same problem. So I think we need to look much more at doing the maths, figuring out what is required to make the system run with the within the expectations of the people, the doctors, nurses, the system as a whole. But also we need to be looking at what is going to change the equilibrium state of the system to have 85% occupancy as a general thing. And the idea that an empty bed is not a bad thing, that's the shuffle space we need to actually manage the block. And I think that's going to require a lot more looking at human factors, which again I mentioned in my submission and I'm delighted to talk endlessly about. And also, as Prof Mallows talked about in his submission, the balance between elective admissions, and particularly elective surgical work, and the acute care admissions. And it may be much more of a balancing act. It may be that if the state wishes to maintain its very good performance on elective surgical, that needs to be factored into these equations. But I really think we need to focus on the system and the equilibrium state of the system and look at it in terms of flow, the inputs, the outputs, the throughputs, where the snaggles lie that stop the flow, rather than just focus on, oh, if only there were more beds, everything would be fixed. If only we paid our doctors more, they would be fixed. If only we had more pharmacists, everything would be fixed. If only we had more GPs, everything would be fixed. It's a system problem.
Colleague?
Yeah, I might just follow up on and tease that out a little bit, Doctor, because this 85 to 90% occupancy rate seems to be one of the key, let's not refer to it as a silver bullet, but it seems to be a key thing that would go a long way to helping this problem, but in the submission, what you say is that without a doubt, the most troubling and tragic impact of ambulance ramping and access block is that it causes patient deaths. So what we're essentially saying here is that if you've got an acute input into the system via ambulances, which people have life-threatening situations, then you need to prioritise and cater for that by creating that 15% vacancy rate so that you can cater for that inflow and prioritise those people. So how would that work in practice? Because presumably you're going to have this ebb and flow system where it goes from 85 to 100 and back down to 85. So you've got to have that 85% vacancy to cater for that inflow. So how would you manage that ebb and flow to get it down to 85? Otherwise, you could end up with a system where just the pressures just gravitate towards 100% all the time. So I'm just curious as to know how that would work in practice.
Sure, okay. So let's accept that there is a degree of ebb and flow, but in fact, emergency presentations are quite predictable, and in fact, things like the matrix system that the ambulances use are designed to smooth that out somewhat. If there is 85% occupancy at an equilibrium state on the wards, that means there is empty beds to go to for admitted patients. We never have a situation where there are more ambulance ramped than there are admitted patients waiting for ward beds in the ED. If those patients were on the ward, then there would be empty ED beds to put those ambulances in. Those ambulances would not be ramping.
Okay.
We can cope with our flow
So
in
effectively,
the
you
ED.
quarantine 10 or 15% for emergency admissions.
I really wouldn't use that terminology specifically because that leads to a catch-22 yes Prime Minister type situation where if we were to set a KPI of 85%, that would be awful because then we would get calls from the ward, no, we can't take your patients even though we've got empty beds, because then we would break our 85% KPI. As I said, it needs to be an unmandated equilibrium state of the system, that the system keeps some beds empty as part of just the way it runs without it having been mandated and therefore not being a KPI. You build a KPI, Goodhart's law says that any measure that becomes a target ceases to be a good measure. And that would be true of 85%. If you made it a target, it would cease to be a useful thing because we would quarantine empty beds that then wouldn't be used for ED admissions because they have to be quarantined as empty beds to meet a KPI. So if you want to actually produce a system that keeps an 85% occupancy, you need to rebuild the system considering the human factors that are going to promote forward flow. And I think that's probably going to involve Prof. Mellow's talk about rebalancing elective versus emergent admissions, and my points about considering the human factors, actually involving the ward teams with flow, having ward team engagement with flow so that they are building into the way that they manage their patients the idea of empty beds is a good thing and forward flow is an important thing, not just for the patients on their ward, but the incoming patients that will be their patients or that are still in the emergency department or are still on the ambulance trolleys coming in.
Can I add to that answer, please?
Sure.
You should probably see the 85% as more of a surge, building in some surge capacity. So, for example, if you had 85% occupancy at 8 a.m., you would have an empty ED. We know for a fact that it's a bimodal peak in presentations at the ED. So we get the bus that comes in about 11 o'clock, the big patient surge at 11 a.m., and we have a big patient surge at 7 p.m. And so obviously those patients that get admitted, and often those patients in the ED are processed and admitted before patients on the ward are able to be processed and discharged. There's a big time difference in terms of when patients present in the morning in the ED and when patients go home from the ward. And so that would build in some kind of surge capacity, and maybe you could see the 85% as a floor, because as well that the 85% builds in a capacity, well, if you have a really, really busy day and get smashed, maybe you're going to trend up a little bit with the aim to try and get back down to that 85% at a later time in the week. Because with the variations there are variations in presentations, days of the week. They drop off during NRL Grand Finals and Royal Weddings. They do go up in other situations. We got smashed by COVID. We got smashed by the floods at Nepean Hospital. So the 85% should be seen as some kind of built-in surge capacity to build in to the differences in the processing the ED and the surges that the ED can have, and the differences in processing on the wards.
Thank you very much. I'll move to a question from the crossbench. Hurst, Deputy Chair.
Thank you. Thanks for that. Dr. Bine, just following on from what we've been talking about in regards to these sort of KPIs, and I note that in your submission you talked about the fact that too much emphasis on a really specific KPI can have a perverse incentive, and I think that you've just kind of explained quite clearly why that would be the case. Are we currently seeing a situation where there's too much emphasis on those KPIs? How do we kind of restructure that system to make sure that the focus isn't on the KPIs? Or is it kind of a situation at the moment where it's just almost like a given that the KPIs won't be met, and they're sort of almost trivial anyway?
Which KPIs are you specifically asking?
I'm talking specifically about the 85% occupancy of hospital beds.
Okay, so that's not a KPI at the moment.
Okay.
And I would really, really encourage it never to be a KPI for precisely the reasons I've said.
Yeah.
I think if it becomes a KPI, it will be a spectacularly perverse incentive and will do terrible, terrible things. I think that the 85% that everybody talks about needs to be as I said, the equilibrium state of the system. When the system is humming, that's what the number is. And it's not something that everybody can be aware of it as a useful number. Everyone can be aware that if it's running at this keeps it humming. This is an optimal situation. And in fact, again, in my submission, there's the only graph I've got in there, I can't remember which page it's on, shows that 85% is roughly the lower, less than 85% really doesn't give us much benefit in terms of flow, but as soon as you cross that border, you get a sharp decline in flow. So 85% is just a useful number for everybody to know, but it should be the equilibrium position of a system that wants to be at that number because everybody is on board with the idea of flow.
I would jump in terms of a KPI. I think that in terms of a KPI question, it would be more in terms of the target, for example, of 90% of patients having to be offloaded from ambulances within 30 minutes, for example. That's a KPI that could potentially be, what's your view on that?
What's my view on that? I think that targets like that are useful because they focus people's engagement in what they're targeting. Every time, however, you present a KPI like that, it ceases to be a useful measure of what it's actually measuring. The only way it is going to improve the thing that you actually want to improve is if it's exactly that. If it's a surrogate measure, if there's a difference between what it measures and what you want to improve, then that gap will be exploited to create a better KPI at the expense of usually decreasing beyond what you would otherwise see the actual thing that you are trying to improve. So ETP is another good example of a KPI. And yes, we do need time targets. Time targets again and again have been established. This is a useful thing. But the ETP time target has now been eroded by perverse incentives and trying to game the system to get it to the best number without having to improve the system, that it's no longer nearly as useful. That's why ASIM is pushing its hospital access targets. It's why you will see in my submission I point out...
Doctor, that organisation, ASIM, or that...
the Australasian College for Emergency Medicine.
Sorry, thank you. That's just for the record, Hansard. Yeah, thank you.
It's pushing its hospital access targets, which, as I said, I was part of the working group that helped work them out. I think they're good. I think they have some issues as well. I point out some of the issues in my submission and how you might get around some of them. But it also, the thing I suggest also has some issues. There is no perfect way to create a KPI that's not going to be a perverse incentive unless your KPI is exactly what you are looking for. Then it'll go hand in hand. What you hope with a KPI is that it'll drag what you're trying to target along with it as you improve the KPI. That has happened to a degree with ETP, has happened to a degree with the 90% 30 minutes. I don't like binary targets. I think that they have a giant loophole that always gets exploited.
And just to, sorry, can I add to that answer as well? So KPIs are good measures of quality. And you need to measure quality to understand how your performance is and to see where the failures in performance and where you can actually improve. The difficulty is when they become a hard target in preference to other KPIs. That's where you start gaming the system. And so, for example, if you make ambulance offloads, I'll use that as an example. As a hard target, we will focus all of our energies on that. But then the 75% of patients that actually present who walk in may not get a different level of care. You see what I mean? From a personal point of view, ambulance trolleys are really uncomfortable. 30 minutes, that's just a random time, in terms of performance. But realistically, 30 minutes on an ambulance trolley is a long time. And a lot of the time, we try and offload due to clinical risk, not understanding that actually it's not a pleasant place to be.
Yeah, that's helpful. Thanks.
I'll just throw one more question in. Just in regards to your submission, Associate Professor Mallows, you made a recommendation about increasing ED staff, particularly around senior emergency staff. One thing we heard a lot in our previous inquiry into rural and regional health was the problems around retaining and regaining some of those senior staff members. And I wondered if you had any recommendations there around, what needs to be done from a government point of view to be able to, to keep and retain and also encourage more of that senior emergency staff.
Oh, wow. So, I mean, there are, so I'll give you, I think it's better to give you more of an opinion experience because there's a distinct divide when it comes to staffing of hospitals. Not just the number in the map that I've given you, but obviously doctors want to work close to where they live. And so there is very, different staffing levels in the eastern and northern beaches hospitals than there are out west. And stark differences, and that is with numbers and quality and seniority. Some of the inner city hospitals have a large number of very senior trainees, and maybe not need as many consultant staff. Whereas Nepean, we really struggled. The trainees at Nepean work really hard, and do a great job. Maybe not as recognised as they should be, but we obviously try and compensate for that by increasing our senior staffing. At Nepean Hospital, we've done certain things with our model that attract senior clinicians to Nepean Hospital. But beyond putting artificial economic incentives there, it's a very difficult question to answer because I said it in a meeting this morning on a different subject about medical registrars. The vacancies travel west. That's just a stark truth. And to be honest, there is a little bit of we're used to it, but we are a little bit jealous when we sort of look down the M4.
Yeah. Okay. Thank you.
Thank you, Chair. Associate Professor Mallows, I just wanted to ask clarification. In your opening statement, you would, well, I'm not sure when it was actually, but you did say in terms of, I think, a new ward that was opened at Nepean Hospital, and you said that the number of, you thought that you were disappointed in the uptick that provided, I think was your language. Now, was that, just to be clear, was there are we talking a new ward with a particular number of beds that weren't provided or were provided and didn't create the kind of uptick in easing access block, or were the beds not provided in terms of fully funded, fully staffed? Do you understand my question?
Yeah. So that relates. So that particular statement related to the new tower that we opened.
New tower? Is that what you're saying? Yep.
Yeah. So on the hospital campus, we've opened a 14-storey tower with a helicopter pad on the roof. And the ED is supposed to move soon. It hasn't. A number of the wards moved across in May, I think. And the tower is future-proofed. So there are empty wards that we don't need now, that we will be opening in the future and maybe up until 2030. So it is future-proofed, and there's plans for a new tower in stage 2, which is again going to future-proof the hospital. But yes, we got, it's in my submission, at a total of 8 surgical beds and 8 medical beds uplift, and obviously the surgical beds were targeted at elective surgery. And that's what disappointed the senior clinicians the most, that we thought we needed more beds than that. Not a lot more, but the fact that we only got an uptick of 8 medical beds is what particularly disappointed us. And that was staff beds, because as I said, the tower is actually future-proof. There's a number of empty wards that will be empty for a number of years.
Yes, I mean, you're talking about future-proofing, and I'm sure that the government will say the same thing, but every witness to this inquiry has used the word crisis. We've heard the words disaster, third world, in terms of what is happening in our hospitals, waits, people dying in corridors, not being able to get the treatment they needed. Wouldn't it make sense, surely, if there are empty wards, to at least consider more beds now?
Yes.
Thank you.
So just to give some additional information to that, Nepean Hospital does have a winter bed strategy, where we have an uptick in staffing over the winter months for a variety of reasons. It was late being advertised. It got approved in June. And obviously with all of the problems with staffing and COVID and furloughs and stuff like that, I'm not sure we actually were able to open any of those beds for the winter strategy. So, I don't want to lump blame inappropriately. There was an attempt to open an extra number of beds to cope with the winter strategy, but again, because of recruitment, we couldn't actually fill them.
Thank you.
They were temporary winter strategy beds, so they would have cut out about sort of October anyway.
Thank you. Sorry, my time's out. I'd also ask you questions, Dr. Byrne, but I don't have any more time.
Good, now to the government members for questions. Any questions from government members?
Thank you. You mentioned, Dr. Byrne, that we need to have a significant paradigm shift. And if there was a simple solution, it would have been done.
I think so. I think everybody wants to find a solution. I think it's an amazingly complex system that is going to require an equally complex solution that looks at all the moving parts.
Okay. So noting that change, or there's always resistance to change, who or how do you start that paradigm shift, and who should start that?
How do you start it and who should start it?
Or who should be responsible?
Look, how do you start it? I've given an outline in my submission of here is an approach. I think that is probably the approach I can think of that I would recommend, but obviously it needs to be tabled amongst higher powers than me before and get appropriate buy-in, because it needs buy-in at every level. Who needs to start it? I think that since the approach I list requires buy-in of the hospital executives, and those hospital executives are not going to be willing to take risks, bear extra expenses, hand over power without something else. It actually needs to come at state level to say, look, this is what needs to be approached. We need to trial something. Here is an approach. Let's get a hospital executive who's willing to give something a go. Doesn't have to be my plan. If somebody comes up with something better, I just need hospital engagement. But give it a go and actually be forgiven for when there are inevitably hiccups and slowdowns and the initial teething problems create unforeseen problems. If those are judged by state as, well, everything's immediately failed, rather than judged as, right, here is a new part of the problem needing to be overcome, then it's guaranteed to fail already. Who needs to be involved? Where does it need to start? It needs to start everywhere. But I do think that there needs to be a state level of acceptance of the system needs changing. It needs a large change. Large change is not going to be easy. There needs to be a disproportionate injection of extra resources to get it up and running, with a view to the fact that at equilibrium, this is the resources we are able to continue to invest in an ongoing and running system.
Has Lou got one?
The Honourable Lou Amato, did you have any questions for the witnesses?
No, I'm fine, thanks, Chair. I'm conscious of time as well.
Okay, well, Honourable Scott.
I'll just ask Dr. Bean, you talk in your submission about some of the challenges with certain patient cohorts. How much do you think that's taken into consideration at the moment in terms of the different challenges to patients, or is it something that is addressed in largely a view where all patients are kept to the same sort of process and rigmarole?
Clearly, every patient has different sets of needs. If we go down to the brass tacks of the access block question, different patients have different needs for different types of beds, which are only available in differing proportions. At the moment, you can see in the report I tabled, there are long waits. You know, it starts off at 74 hours, 24 hours, 110 hours, 27 hours. A lot of these patients are looking for mental health beds in my shop, but it is not universally so. You can see a little bit further down, 24, 26 hours admitted via the operating theatre. Those were patients who were waiting for a bed so that they could actually then go to theatre and would have a post-operative bed ready for them. So it's not universally just mental health. There's a lot of access block amongst the aged care component, so people needing a specific locked ward bed so they don't wander, so that in a state of dementia or delirium, they're not going to come to undue harm that's not available for the level of care required on an otherwise bed, like a respiratory ward bed. There are some requiring monitored beds or BiPAP beds or ICU beds. So yes, there's a variety of difference, and all of that's taken into account. A lot of the long waits are because a specific type of bed is not available immediately. A lot of that is mental health beds. Some of that is the access block on the geriatrics ward, but some of it is just generic beds.
Thank you. Thank you very much. Sorry, Professor, you had something to add, or?
Well, I didn't want to interrupt the questions from the inquiry, but I just wanted to get back to something about your question about, well, what are we going to do next? It's really an exercise in attitude change. We have to make a decision about what we want to do with the limited, resources that we've got. Surgeons, we want to do operations, and there are people that should get operations. And I see people that come to ED because they don't have operations. You see what I mean? So I'm not, I just want to put that into the debate, that it's not all about ED, it's about a health system. But we do need to have a sophisticated conversation about, well, what are we going to do? Are we doing too many operations? Do we want to prioritise ED flow? Do we need to rejig the balance? And there's all kinds of, you see at the moment, there's debates about, tax cuts, and I'm not going to take sides, but clearly there are people that feel one side and there are clearly people feel another side. And at the moment, we've just got this tit-for-tat debate and no one's actually making a decision about it, you see what I mean? Now, that's a bit of a superficial example, but when you look at the health system, it's like no one's decided how many operations we can actually do functionally within our health system to maintain functioning EDs and to avoid ambulance ramping. You see what I mean? We just go, yep, let's do this number of operations because there's this many people on the waiting list. I think those are the very sophisticated conversations we need to be having, and it ultimately gets down to an element of attitude change, and how people think about different stakeholders think about the health system and what we should actually be doing.
Well, Professor Mellows and Dr. Bean, thank you very much. Very helpful, your contribution, which augments very nicely their submissions. I'm sure there'll be some supplementary questions arising from members having a chance to read Hansard. So you'd be agreeable that through the Secretary of the EA is back with you with some further questions arising from your evidence today? That'd be okay?
Yes.
That's great. Thank you very much. Once again, thank you both very much. It's been very, very helpful. Thank you.
Awesome.
We'll move straight away to our next two witnesses, please. Well, good morning and welcome to you both. Actually, it's gone afternoon, so good afternoon and welcome to you both. Thank you very much for both making the submissions and making yourself available today. I know you're both respectively very busy in your particular role. What we'll need to do first is get through the formality of having you sworn or affirmed to give your evidence. And that'll require, perhaps if we start with the Associate Professor, just move across then to Ms. Dyson, your name, position, title, and to be clear, in regards to that, whether you're appearing today in your own capacity or representing an organisation, so we're clear about that, and swear either an oath or an affirmation, whichever you prefer, the words of which should be made available to you. If not, just raise your hand. So, Associate Professor.
My name's Graham Rees. I'm here in a personal capacity. I do work as the Director of Intensive Care at Blacktown in the western part of Sydney, predominantly. I've been on the Medical Staff Council for 20 years. Half of that I've been on the executive. And also I'm in the State Intensive Care Executive. I'm here as a private capacity.
Thank you very much. And then either an oath or a affirmation, whichever you prefer.
I swear that the evidence now about to be given by me shall be the truth, the whole truth, and nothing but the truth, so help me God.
Thank you, Professor. Ms. Dyson.
Thank you. Good afternoon. I'm Sophie Dyson. I'm a director at Taylor Fry. I'm addressing the committee, I guess, from my dual professional backgrounds as an actuary and a paramedic. The submission was written from Taylor Fry's perspective as a company rather than the peak body of actuaries and data analysts. And my paramedic, I guess, references will be entirely personal.
Okay, thank you very much. And can I invite you to take either the oath or the affirmation, please?
I solemnly, sincerely and truly declare and affirm that the evidence now about to be given by me shall be the truth, the whole truth, and nothing but the truth.
Thank you very much. Now, as I mentioned in my early comments, I'm very grateful for the two submissions. Professor Rees, your submissions obviously been provided to us and it's been processed. And it stands as submission number 22 to the inquiry. It's been uploaded to the inquiry's webpage and forms part of evidence to the inquiry. Ms. Dyson, the same. Thank you very much. The submission has been received. It stands as submission number 23 to the inquiry, been processed, uploaded to the inquiry's webpage and stands as evidence to the inquiry. So thank you for that as well. But both very helpful submissions, and take those as read by committee members. So in terms of your opening statements, which I'll invite you to make shortly, there's no need to quote in detail from the submissions, but set up the key points that you would like to particularly draw to our attention, and that will then open up an opportunity for questioning. We've got members of the opposition, the government and the crossbench, and we'll share the questions between ourselves. So we start with opening statements. Associate Professor, can I invite you to make an opening statement if you wish?
Thank you. Have you got, I dropped in something this morning, have you got that?
Yes, we're about to...
Because I'll wait
that, yes.
to go out because it's a little bit...
No, Associate Professor, we'll happily wait a couple of moments. That's wonderful.
I think both sides are correct. I've been very impressed. We've been working predominantly from Blacktown Hospital. We've been working with the state government for a number of years because it's an area of a lot of growth and change in that part of Sydney. The National Health Reform Agreement says that its first primary responsibility is to strive to eliminate differences in health status. And we've been very impressed the way New South Wales Health has aligned, and in the thing that's being handed out to you now, if you want to have a look at page 5, New South Wales Health has aligned extremely strongly to that vision, which is of equity of outcome, as opposed to simply equity of input. And cancer is obviously going to be a major burden. I've put the New South Wales Cancer Plan there, page 5. It very clearly says their first goal is equity of outcome, and talks about the patient experience. You can see in orange. And again, the overriding principles, the first overriding principle of New South Wales Health is equity of outcomes. And I think that is a major initiative, and we've seen very strong alignment with New South Wales Health with that over the last couple of years. The second, I think we do have a good health system. Page 10 of the handout. It's published in the middle of this year from the Australian Institute of Health and Welfare. You can see significant reduction in mortalities. Cardiovascular disease, cerebrovascular disease, infectious disease, they're dropping significantly in the last 10, 15 years. So there is no doubt that we do have a good health system. There are new challenges. I won't go to them now. Youth suicide, the elderly people, dementia, the last year of life. So there are challenges, and as I heard a little bit of the last guy speaks, there are difficult conversations which we need to have, and I have a suggestion where they should be, but that's not what my opening statement. So I think that we have a good health system, and one patient will come to hospital, and he's patient 1, and he will say, I've got chest pain. It's exactly the same as when I blocked my LAD, and I had a stent put in at X and Y hospital. Here's my medications, and here's the mobile phone of my specialist who I spoke to half an hour ago, and he expects me in the cath lab in 2 hours. That's patient 1. Patient 2 says, I've got this discomfort in the chest. How long have you had it? Well, couldn't get to my GP, or I got to my GP, he said to come to hospital, but I couldn't get to hospital, so I waited for a week to see if it would get better. That hospital may not have a cardiac catheter lab. He may not have a general practitioner. And I guess they're different patients. They're different patients, and we did a review with the Australian Institute of Health Innovation of the best funding models in the world for universal health care. And it's by Robin Clay Williams and Jeff Braithwaite, and the references in there and the cover pages there, I'm sure you can find it. Look, the Scandinavian countries, New Zealand, Canada, similar universal health systems. And the key findings I've put in dot point form, which is on page of the submission that you've got there today, page 8, which is not labelled, but it's clearly the one for page 9, which does have a label.
Yep.
And it's the point that in the ED, is staffing the same in every ED? Are the patients coming in the same in every ED? At the back end of the hospital, are there as many consultants rounding in all the hospitals? For early discharge, do all those consultants have rooms close by to the hospital that can be accessed by the patients? Or is there a gap which precludes them being used? And so I don't want to go too much in the detail of that in the opening statement, but the point, if you look at slide 29, my second last point, page 29, Business Analysis Unit of Western Sydney looked at every patient coming to ED for the first 9 months in 2020. Every ED patient coming, and we looked at their index of relative socioeconomic disadvantage or advantage, because that explains 84% of the difference in outcome. And so the business analysis unit looked at the address of every patient and their index of relative socioeconomic disadvantage and advantage, which is one of the ABS things it collects every 5 years. And we mapped those coming to the ED. The question was, are they all the same patients? And you can see I've deleted the names of the hospital for this record, but there's Hospital 1, Hospital 2, Hospital 3, and there's another hospital, Hospital 4, in a different LHD. So the question, even forget the number of patients, is that the characteristics of the patients the same? And in terms of ED bypasses, I heard a little bit of the session the other day about the psychiatry, the safe homes.
Yes.
Pre-hospital affects post-hospital. So what we've been extremely impressed with New South Wales Health is they are looking into the nuances. And the last point I'll make in the opening statement is relates to there's a graph there on page 4.
Page 4?
Page 4.
Yep.
It looks like that. From the Australian Institute of Health and Welfare. Yep.
Thank you.
And that relates to burden of disease work. Burden of disease work. And you can see it divides the population using the same thing that I said, index of relative socioeconomic disadvantage. 5 quintiles of our society, quintile 5, the least disadvantaged, down to quintile number 1. And you can see that there is a difference. The dotted lines on the outside is how long you live. The red non-dotted or straight lines are how long you live and being healthy. And I think the most difficult discussion that needs to occur is, if that is our society, and I know that the gross regional product for Blacktown alone is $17 billion. $17 billion. Western Sydney is Australia's 3rd largest manufacturing area after Central Sydney and Melbourne. The point is, if you had to look at your health system as a whole, where would you put your resources in that situation? Does health dollars make a difference? There's an example here. I've taken too long that I'll let Sophie talk, but there's an example here from COVID where we worked with a non-infectious diseases hospital doctor at our hospital, worked with community teams, community partners, and at least produced a 50% reduction in the COVID death rate. Pre-hospital intervention. So, sorry.
Thank you very much for the detailed opening statement and specific references to your supplementary document. Ms. Dyson.
Thank you. I mentioned I'm addressing the committee for my dual background as actuary and paramedic. I've spent almost 30 years as an actuary and more than 20 working in Australia's health system, providing advice on costing, funding, strategy and operational change, from private insurance to all levels of government, across inpatient and out-of-hospital settings. The reason for mentioning that is because I do think this requires a whole-of-system solution. I spent 5 years in frontline and corporate roles at New South Wales Ambulance and still do a shift a week on road as a casual paramedic in southwest Sydney, and I mention that because I see firsthand the impact of ambulance ramping. The terms of reference cover access block, ED performance and ambulance ramping. Ramping is not really a term used by paramedics. I call it bed block, or more formally out-of-hospital, transfer of care delays. Access block causes ED delays and overcrowding, which flow on to delays in the paramedic ED interface. The chain of causation is important because it indicates where the solutions lie. Boosting effective inpatient capacity, either directly or indirectly, by adding new beds, improving patient flow and or avoiding admissions entirely through better primary and community care. And as Dr. Bine said in his appearance, it's about creating empty beds, not just adding more beds that will become filled. The issues are not new in New South Wales or anywhere else. And on many metrics, New South Wales is outperforming other states. The papers this morning were full of South Australia's underperformance on ambulance ramping. A lot's already been done by New South Wales Health in partnership with the Commonwealth, but the fact that we're here today indicates that there is still more to do and also that it's not easy. The solution requires a sustained, multifaceted approach across the whole system. Because we're actuaries, our submission talks about costs and data. It's important to acknowledge that financial incentives and convenience drive both the healthcare that people seek and the healthcare that providers offer. We also talk about cost because it's a component of value. Government funding is scarce, and any investment in health needs to offer the best value for money. Data can help in a number of ways, linking administrative data sets to see how patients use services and their pathways through the health system, modelling the impact of initiatives and their interactions with the rest of the system, and monitoring programme effectiveness. Separately, giving clinicians real-time access to patient clinical information will support the provision of coordinated care across different settings, which is a real challenge at the moment. Our recommendation is not simply build a model. It's to use data and modelling to complement getting more immediate stuff done. In that respect, I will be focusing on intra-hospital processes and flow, residential aged care and mental health. We don't need to fix it all, just to create enough capacity so patients can flow through the system more easily. The pandemic has been an exceptionally challenging time for many, but it has also demonstrated how quickly and how effectively the health system can cooperate and innovate. Thank you for the opportunity to appear in front of you this afternoon.
Thank you very much, President. It's a very precise and clear opening statement. Thank you for that. I'm sure it'll generate some questions. So we'll start with the questioning. Start with the Honourable Mark Buddy.
Thank you, Chair. Perhaps, Professor Rees, the conclusion, as I take it from your evidence, is that you've got to have a horses for courses approach depending on a couple of factors. Obviously, in the case of Blacktown, which is your sort of area that you service, so you've got exponential population growth coupled with socioeconomic challenges, which are feeding into disproportionate demand for healthcare. And what you're essentially saying is that the concentration of resources isn't proportionately allocated based on that disparity. Is that kind of a rough way of summarising what you're on about?
Roughly. Can I refer you to page 6 of the new document there? Page 6. So again, this is an Australian, Sir Michael Marmot. This is his work, which he presented to the College of Physicians. I'm also a general physician. He's an expat Australian who was chair of the World Health Organization for Social Determinants of Health. And so on the right are the most privileged, if you like, the most disadvantaged are on the left. And now the vision which Australia and New South Wales Health have set is that we have equity of outcome, which is the dark blue line or the dotted blue line up the page. So, and there is a law called the inverse care law, but we'll forget about that. You can see just by looking at it that to get to the blue line, if you're in the more disadvantaged groups, requires a different amount of resources than if you're on the right of the graph. So if you want to make a difference and you're a health professional, if you really want to see, if you want to do 10 hours work and make 20 hours of difference, you might work in a certain place. Of course, you can do research, but that's great, because that really is a multiplier effect. But so yes, and that's why I say we've been very impressed with New South Wales Health, because we've sat down with them, with our hospital executive and with the LHD executive and also with the department. They have recognised that this is the case, and I think that they were called in our hospital equity projects. And I think we've run this scheme for about 2 years since we've had discussions with New South Wales Health. I think there may be 20 of these equity projects that, as you've said, they've come from the ground up with support of the executive. So innovation is required. It's got to be guided, as you said, by what are the problems here. New South Wales Health can't say, well, they're the problems because they don't.
Just on that point, though, Professor, presumably this was to some extent predictable many years ago, given that governments are in the business of predicting demographic trends, socioeconomic status. They have the data harvesting and ability to predict these sorts of things. But what you're saying is that it had to be brought to their attention. And now, would it be fair to say we're playing catch up, given some of the stories we've heard in those health districts?
I think COVID was a stress test in some ways. It was a stress test of if we go X% more, how do we cope? When we met with the department, they've got this information and they are acting on this information. So there is, I'm not a funding expert for New South Wales Health, but there is funding for this equity. There is equity, that it would be a different name, but there is a name. They also have a bucket of money for socio-economic disadvantage, if you like to call it that. I guess one thing that we did, which is probably new, we worked with the finance department for one of the universities and actually did a costing study. How much is that? And that paper has been published. Tanis is the lead author, TANNOUS, and it's referenced in these documents. So no, I think New South Wales Health was reading these documents, and I think as clinicians, I think actually the responsibility, if we're going to talk responsibilities with us, often we became too busy just doing the work.
Sure.
We have groups called medical staff councils, which I've been on for a number of years. And I guess one of our major jobs is to look at the system and to flag to our executive and to flag to the LHD and the department what are the issues that need to be done. It requires thinking beyond myself, beyond my department, beyond my hospital. And I think if anything, we are the ones who are sitting on the bed with these patients.
No, I understand, and it's very important to just talk to the real people who are actually living and breathing this stuff 24/7, right across the whole range of portfolios. But I want to ask you just one more before I hand over to my colleague. Do you think that mismatch in socioeconomic status and population growth, which is increased the demand disproportionately, has the funding increased sufficiently to close the gap? Is my question going forward.
Well, there's a gap there today. It would always be nice to be where we've got equal outcome. As I said, we've reviewed the best in the world, and we're confident now, looking at what New South Wales Health is doing, the value-added approach that they're taking now. That is the best in the world. So no, I think, as somebody mentioned, I heard this morning, inertia probably. My peers work really hard. All of us would do lots of hours that aren't reimbursed. But I think it is our system, and I think it's really up to us, the difficult discussions that were talked about before. We're probably the ones who need to take the time to have those discussions so that people know, because I don't think there's anybody that you talk to who, when you lay the facts out, it doesn't see the issue. So I think what's happened is but no other country is as, I think, if you probably saw the COVID modelling that New South Wales Health did. That was absolutely phenomenal, the number of variables. And in fact, I put a chain at the front page of this thing there, a gold chain.
I was wondering what that was about.
The gold chain is because the cleaner is so important. If we get multi-resistant organisms, I'm an intensive care director. Intensive care's had to close down because there are too many. So imagine what that does to a hospital. So we do have actually an excellent health system in New South Wales. Gold, it is precious, it is worthwhile, it is not, it's world leading. Our intensive care network is the biggest computerised, biggest in the world. We are not second in many ways. So but it's like this topic today. Ambulance is looking at it from one point of view. The ED can look at it from another. The back of the hospital will look at it another. And really, as we've said, it's actually probably much more complicated than that. So the gold chain means it's something valuable, where it's all linked together, and there's many aspects to it. Sorry.
No.
Just following on from that, just try to appreciate what seems to be anyway a potential tension. Take it that we accept the proposition, Associate Professor, that your argument is that with respect to clinicians in emergency departments on the ground, I'll use that phrase, have been particularly work focused on what's immediately in front of them, and perhaps, using your words, not talking or engaging in terms of the exploration of some of these issues arising from or that are being sort of drawn out by this inquiry. Is not, though, the fact that, as you've just said, you've got the likes of ambulance, you've got the likes of, for example, we had this morning people talking on behalf of pharmacies and pharmacists in hospitals, that this is obviously multifaceted, multifactorial, that it is inevitable, and in fact, how can it be any other way? But there's got to be that principal driving force from a central point to try and link this all together and get those conversations, those lateral conversations together to deal with these matters. So no matter how enthusiastic a given group of ED specialists might be and motivated, say, like yourself, to want to talk and talk in a holistically and, dare I say, a broad global fashion, there's got to be a driving focus, because at the end of the day, that's going to create that ability to articulate and link up these component parts to try and get the synergies we want.
I think that's very true. I think 2 points. One is the population in New South Wales, now is different to where it was 5 years ago, and the socioeconomics of it are different as well, and all the other input different as well. So we have changed to how we were before. In terms of vehicles for us to escalate up this information to the department, every hospital, I think, has a clinical council where doctors and nurses sit together, the heads of department, the senior nurses, and that is our opportunity to escalate that up. And I guess that's one of the reasons I can only speak where I spend most of my time, Blacktown, Mount Druitt. We have a very active voice, and we have an executive who listen very acutely to that, and they take our message and convey it to the levels above that in the department. So I think that every hospital, I think there'd probably be 30 medical staff councils, but above the medical staff council, that's just doctors. And we have a certain role, but is the clinical council where the allied health people sit, where the head nurses sit, and the patient flow people sit. That is our chance at every hospital to have a voice, and that then feeds in through the structure.
I won't debate it, but it should feed in, I think, is your position that you take. It should feed in. I'm not quite sure whether the evidence we've received necessarily reflects that.
I can't comment.
Anyway, to the Deputy Chair.
Thank you. I might start with some questions to Ms Dyson. I read through your submission, and I note in the submission that access block can be caused by demand factors, supply factors, and patient flow were the sort of highlights in that submission. Can you expand on a little bit more on these factors, just to kind of give us a bit more understanding and the kind of barriers experienced within that process that can lead to the delays for patients that would be ultimately discharged?
Sure. So in terms of breaking those down, demand is who's coming in the front door. And that may be, the sort of quarter of people that come in by ambulance, or 75% that actually come in under their own steam. The demand, I guess, is created. What's been interesting, I guess I'll preface this by saying it's been interesting to see different submissions written from different people's point of view. And I feel very strongly that step one of this process is for everyone to sit down and have a common understanding of the situation and the end-to-end process that we go through here. Because if you only see something from your own perspective, it's difficult to understand the consequences of your actions. So in terms of demand, it's the people coming in with, to ED. In terms of supply, we've talked, Dr. Byron was talking about the 85% kind of measure as being a kind of appropriate one for capacity. And if there is insufficient inpatient capacity and that's exceeded, it just slows down the whole process. So that's a kind of supply issue. There's a kind of indirect supply issue if you're talking about where people go once they've left hospital, and particularly people who are not able to care for themselves, who might be elderly in residential aged care or have a disability. If there is nowhere for those people to go, they have to stay in hospital, and that creates a block. And then when we talk about flow, again, coming back to Dr. Bynes' point earlier, it's not about beds, it's about empty beds. So it's being able to move people through the system to free up that capacity. And yeah, I guess just come back to, I guess, stressing that chain of causation is access block causes the ED delays, causes the ambulance delays.
Yeah, thank you.
Could I just add
Yeah.
on the patient flow business?
Mhm.
Because you know, this even transfer of care that we talked about before, yes, by having hospital meetings twice a day, you can focus attention to make that better. So on patient flow, let's say you're at hospital A and there's a registrar who's just passed his exams. His decision making, Scottish reviewed their health system and they said if you run on a registrar-based system, it will be 70% efficient. If you run on a consultant-based system, it will be 95% efficient. So if you're at Hospital 1, where the consultant does 2 rounds a week, and he's expecting his more junior registrar to make discharge decisions, he'll get it right 70% of the time. What that means is he'll send home patients who will come back, or he'll keep in patients which should go home. You now work at Hospital 2. Hospital 2 has got a bloke who's come from the UK, who's done his fellowship and is just waiting to get on the Australian stuff, so he's a very good junior doctor. So the same senior doctor does 2 rounds a week, that he is so confident in what his junior is saying that those decisions are 90% accurate. And so that's where, so to us, if I get a call from my emergency department, if I get a call from a consultant, in 5 minutes I will accept that patient because what he says is gold, is like gold. If I get a call from somebody else and what they say is contradictory all the time, I might even ask for more tests. So it's flow is only a product of high quality decision making. And that's the point that somebody made before this morning, is not just getting doctors in these places or senior nurses. It's high quality decision making, and with high quality decision making drives flow. If the real metrics were when was the high quality decision made, that's the metric. Otherwise a poor junior can follow a protocol and take 6 or 8 hours to follow a protocol. A senior who has got practiced pattern recognition can say in 5 minutes, just go from 1 to 27, don't go the 26 steps in between. So that's the point to me, to make the system work. How do we get the best doctors spending the most time where they're most needed? And I've heard Director Generals say that for a decade. And doctors work for work-life balance. We are no different to anybody else. If I can knock off at 3 o'clock and be home at 5 o'clock, yes, there's professional reasons, but maybe you've got a family. And so work-life balance, how much can you squeeze in? Yeah, we can all work 8 to 8. Of course we can 8 to 9, 8 to 10. And most of you sort of, people say type A personality, whatever, to be a doctor or a senior nurse, doesn't matter. But if we're into sustainability and resilience, then many doctors are after some sort of a balance.
Thank you.
Thank you, Chair. I might go straight to questions for Ms Dyson as well. Thank you for your submission. It's very interesting, but for those of us who aren't actuaries in this room, which I assume are all members sitting around this committee table, could you just explain a little bit further where you say you encourage government to harness existing linked data assets to explore the impact of different options on access block, ambulance ramping and ED performance? What examples in terms of the existing linked data assets, exactly kind of what that would be, in terms of making recommendations to government?
Yeah, thank you. So the issue about using the data is not that we don't have it.
Yeah.
We do. We've got a lot of data and a lot of administrative data. So we've got ambulance data that all forms part of the master linkage key for New South Wales. We've got inpatient ED data all flowing in there, community, outpatient data as well. And we've got also, there's a Lumos data set, which brings in some of the GP data as well at Commonwealth level.
It's Lumos, you said, just for the purpose of Hansard, LUMOS.
Yeah, so there's a variety of sources that you can link together to understand, I guess a sort of complex example of of work that has been done in this respect is in sort of communities and justice, linking together health and education and sort of communities and justice data to look at expenditure for different groups of families and the kind of pressures that they're under, whether it's mental health or various characteristics that will indicate whether or not they will have higher needs for government services, and actually modelling the impact of interventions and how that will affect their kind of trajectory and the associated cost. So this is work that can be done. And coming back to your question on health specifically, it's not a question of lack of data. It's not even a question of the lack of technology to do this. You know, the kind of advances in data analytics and techniques over the last few years are kind of astonishing. I think it is really about someone taking responsibility and saying, right, we're just going to do this, because health data is a really sensitive area. Everyone is very concerned about privacy, with good reason, and protecting people's privacy and the data not falling into the wrong hands. And I think it would take kind of political will, from the top to say, we just need to do this, because we have the capability and the data.
Because I think one of the very interesting parts of your submission and what analysis like this can provide governments is that kind of savings, if you like, which we've heard from other submissions as well, savings in terms of investment in preventative care, or you use primary care, what might be the impact on patients, ambulance and ED service, and what might be the potential savings from investments in primary care. I don't think we do that. Our government doesn't necessarily do that in terms of, we've only got as I think a witness said yesterday, we've got a finite budget, we can only spend so much. So you're also recommending then, I assume, is that we can't measure in some ways, the government's not measuring spending in other areas that might remove spending in other areas that eases the public hospital expenditure, for example. Is that also what you're saying?
Yes, and I think I acknowledge that it is really difficult. You know, there's talk about investment in primary care is going to yield benefits in the future. You can't say to someone who's lying in resus, sorry, love, but in 5 years' time, 10 people will be saved. It's just not, so that's why it makes it so difficult to sort of say invest now for benefits later. And I think this is a process that needs to happen alongside the just getting stuff done. I think it is identifying across the system where the investment needs to be made and keeping that system-wide view. Because with the sort of complexity of funding and provision arrangements between Commonwealth and state government, it's very easy, and the blame game was written 15, 20 years ago. Nothing's changed. There are opportunities, if there are opportunities for another part of the system to take responsibility, it will take the cost of that, that's what will happen. So I think it's keeping a system-wide view, thinking about the future, thinking about interactions, and also thinking about substitution. So I raised in my submission, I guess, the point that if you send an ambulance to something, that's about $1,000 broadly. If someone goes to the ED, it's about $600, $700, depending on whether they're admitted or not. If they go to their GP, it's much less. So it's a question of where that care can be provided most effectively and most efficiently.
Thank you very much. Government members, can I invite Lou Amato or...
Let's go to the Lou in the Alps.
Lou is joining us from, is it Switzerland, Lou, or...
Torino.
It's mysteriously blurred, whatever it is.
Very close indeed. My question, I'll go... Kate asked a very good question. I was going to ask that one, but to go a little bit more, Ms. Dyson, using your linked health system data, right,
So I think we've got a fair way to go in that. I'm not actually part of that team working on that engagement, so I can't give you exact details. But if you would like to know, I'm happy to come back to you with a time frame later.
Take that on notice.
Take it on notice.
Appreciate it. Thank you. That's all I have, I'm afraid.
Right, okay. Well, it's over to the Honourable Scott.
Thank you very much, Mr. Chair. Look, and I'd like to thank both witnesses for your evidence here today and your submissions and detailed subsequent submissions as well. Ms. Dyson, I think one of the comments that stuck out to me from your evidence earlier was that everybody comes to this effectively with their own perspective and ability for us to sort of stand back, and I guess this committee in looking at this, to stand back and try to work out how everyone's perspective works into the entire system. What sort of mechanisms do you see that we could best take that approach to be able to pick up all of those little cogs in the wheel, whether they be the pharmacists this morning or whether they be surgeons in Western Sydney, and to be able to distill that to work out each of the little cogs in the wheel, so to speak, and how we get to the end game of being able to alleviate this issue?
Thanks. I think get everyone in a room, either actually or virtually, and just sort of say, step me through what you do. What do you think the influences on your workload are, and what do you think the impact of what you do has on the rest of the system? And just get that perspective, and just literally step it through. I was talking to a friend of mine who's a specialist, and he was sort of talking about hospital flow processes and the need for more senior clinicians to be involved in decision making. And from his perspective, he was saying, when things get really busy, ED just kind of admit people to get rid of them. And actually not having that specialty involved in the admission means that you end up with people in beds who then need to be discharged. That doesn't happen instantly. So you're actually just perpetuating the problem by not, I guess, understanding the consequences of that action that you've taken.
Thank you. And also I take from your opening statements where you said that New South Wales in comparison to other states was doing well, but of course the fact that we're here today shows that there's a lot more to be done. Stepping back from that in a second, wondering, is there anything we can learn from approaches being taken in other states, or is there anything we can learn from approaches being taken internationally, or is this something where we really need to go back and look at first principles to work out the solutions?
I don't think we need to look at first principles. I think that there are elements of a solution in place, and I think if you were looking, I see the initiatives that New South Wales Health have put in place. I see the kind of level of capacity that the hospitals are working at, and you sort of think, right now you just need some breathing space. And that's why sort of in the short term, I mentioned in my opening statement, I will be looking at sort of aged care and mental health because, and again, check, is my perception real? But the user data...
Mind you, we've had other witnesses that have said exactly the same thing today, so that sort of corroborates the evidence.
But I think, user data to say, well, where is the problem? And as Associate Professor Rees pointed out, it's not the same everywhere. It's horses for courses. But work out a couple of areas where something that you do is going to have bang for buck. It's going to affect a big enough cohort of patients that you can actually just ease that capacity and then start planning for the longer term. So as an example, with residential aged care, you've already got infrastructure there. Everyone's in a hospital bed. There's nursing staff there. There are already outreach programs in place, and actually making a decision about what should and shouldn't be transferred to hospital and delivering more of that care within the aged care environment would free up, I think, of the kind of breathing space that you're looking for, would free up some of that capacity. In terms of initiatives from elsewhere, something non-clinical, but I see as a paramedic going to residential aged care facilities, you frequently get there and the patient says, I don't want to go to hospital. And then you ask for the advanced care plan and it says, not for transfer to hospital, not for fluids, not for this or that. And you say, well, why are we taking them? Oh yeah, that's fine. The son just wants them to go. Okay, but what do they want? So we don't respect or listen to elderly people enough. We write it off because they have cognitive decline. I think it's perfectly possible to be experiencing cognitive decline and still be absolutely clear that you don't want to go to hospital. So I think one step that could be taken from an administrative perspective would be to have a standard approach to care planning. There is no one form. Advanced care directives, there's no one sort of approach to producing that. So it's actually really difficult to, I guess, have a piece of paper and say, yeah, this matters, I can count on this. And in the UK, they have something called a respect form, which is a really standardised way of documenting your wishes, and everyone follows it. But it also gives the patient, at any point, the freedom to make their own decisions contrary to that.
Thank you very much, Ms. Dyson. And Associate Professor Rees, when you were talking through the examples before, and I thought they really showed a good point in the terms of how you can have exactly the same system in place, but the quality of the individual may be a variable in terms of what's required. So your 75% example and your 95% example in terms of what sort of information you're getting. What do you see that we can do to improve the consistency or change those processes so that there can be more consistency across the system?
I think...
Is it even possible, I guess, in a sense?
I think you want... medicine is... the practice of medicine, and I'm saying, and nursing, and I'd imagine allied health is, and that's pharmacy, is a bit like it. Sometimes it's caught. So to have the best leaders working in the areas of most need, because you then become a role model, and it's what you say, but it's also what you do. And so I think that if we could look at the staffing structure at the hospitals that in this state where there is a longer period of time kept healthy, look at that structure. And at least, if you can't replicate that structure in the hospitals whose outcomes aren't as good, the doctors must be unbelievable if they're going to have a better, So you're saying, if the best doctors get those results in the best hospitals, how can other doctors in less resourced hospitals come up with the same results? It doesn't. It's tricky. Could I just say another couple of points, if I may? Mark, you asked about, Honourable Mark Buttigieg, you asked about the linkage between socioeconomic status, or the relative index of relative socioeconomic disadvantage and funding. I think that actually has gone up to the National Committee, IPHA, for reconsideration from New South Wales Health. So I think that point has been raised. There is funding associated.
The National Committee, can you just elaborate on that?
Well, there's a independent hospital pricing authority, IPHA.
Right.
And so it looks at weightings and cost of production, if you like, cost of production. So a patient who this patient, I've responded to that treatment, I feel better on day 2. Another patient may take a couple of days to work it out. So the costs of production are different. You've got to pay your staff a bit more because they're locums. And if they're a locum, are they used to the intricacies of your system, or are they not used to the intricacies? So in other words, the cost of production differs, and that's what New South Wales Health, I think, have now taken to the national body, flagging. So that was an answer to that question.
Sorry to cut you off, Associate President. We've got to move to...
Sure.
So can you be very quick with that final point you're going to be making, or... I'm sorry.
Oh, yeah, the last one is very quick. What to do. Louise Marcus is the chair of the Australian Institute of Health and Welfare. Those documents are phenomenal. And most of our planning at Western Sydney comes from those documents. So, I think we have committees and can get people together in a room with deference to Sophie. But we've got committees meeting already, and if this could be part of the business as usual, then those committees are value adding. And I think every medical staff council and clinical council should read the AHW documents. A lot of the stuff coming out of our own New South Wales, BHI, tremendous information. So I think really, if each hospital and LHD responded to those documents saying this is how it affects us, what am I going to do about the youth suicide stuff? And if my LHD has got a lot of cancer patients, what are we going to do? I'm not going to do liver transplants at Blacktown because the state doesn't need another centre. That way you can fit your own little niche into the global.
Yeah. Well, thank you both very much. It's been wonderful to hear from you to bring what is a huge amount of expertise to the table, which has been added very nicely to the submission. So thank you very much. And there may be some supplementary questions arising from your evidence, and the Committee Secretary will liaise with you. Thank you. Okay,
Thank you.
sorry about going over. We'll be back at 1:45. Thank you very much, and thank you to the government and particularly their most senior witnesses that come on this afternoon for what is our last session of the second and final day of the inquiry. Now, we just need to go through the formalities, although I'll just check, is there any standing oaths or affirmations which apply in this case? Okay, so sorry to do this to you, and I know you probably know this like the back of your hand, but starting with Mr. Morgan, I'll get, Dr. Morgan, get each of you, just for the record, to state your name, your position title, and either an oath or affirmation, whichever you prefer, the words of which should be there. If not, just raise your hand. So, Dr. Morgan.
No problem. Thank you. Good afternoon.
Thank you.
Dominic Morgan, Chief Executive, New South Wales Ambulance. Today I make an affirmation.
Thank you.
Solemnly, sincerely and truly declare and affirm that the evidence now about to be given by me shall be the truth, the whole truth, and nothing but the truth.
Susan Pearce, I'm the Secretary of New South Wales Health. I swear that the evidence now about to be given by me shall be the truth, the whole truth, and nothing but the truth, so help me God.
Thank you, Ms Pearce.
Matthew Daly, Deputy Secretary, New South Wales Health, and I'll take the oath.
Thank you.
I swear that the evidence now about to be given by me shall be the truth, the whole truth, and nothing but the truth, so help me God.
Thank you very much. Now, as I indicated just off record before we started, the government's been generous enough to, subject to perhaps needing to tidy up something at the end, they'll cede their, what is half an hour effectively, leaving then just half hour for the opposition, half hour for the crossbench, which means we'll have an early mark if at all possible. And we'll be sharing the questions there between the opposition and the crossbench. So thank you all once again for coming along. Can I just start with my first question to the Secretary? And it's regarding a piece of evidence from Wednesday. And I have to say it's a complimentary piece of evidence directed to yourself, quite specifically, Secretary. It was from Mr. Gerard Hayes from the Health Services Union, with him reflecting on the matter of what's being used, the term ambulance ramping, for the purposes of this inquiry, and I guess it's the more broader vernacular, ambulance ramping. But Mr. Hayes says, and this is on page 46 of the uncorrected Hansard, and you may not be aware of this, but I'll just sort of draw it to your attention, because I think it's important to reflect on this. So it's page 46, and it's at just about really a quarter of the way down. I'll just read part of the quote. Talking about the issue of the ramping, it says, those shortcomings didn't come in the last 2 weeks, they came over the last 10, 12, 14 years, and we need to take ownership of that. That's what he says. And he goes on to say, health has been under stress for the last 2 years, he makes that comment. In fact, more than that, really, it's pushing 2.5 going on. Health was under stress before that, last 2.5 years. He goes on to say, as I said before, and this is a repeat of what an earlier statement was, in 2016, ramping was so bad that Susan Pearce had to get involved in that. And to be fair, it's probably a comment that could have been made better. But to your point, in terms of covering a whole heap of issues over the past, particularly 2 to 4 years, and my dealing with the previous health minister, who was incredibly poor, I'll leave that aside for a moment, it is a hard job. So there's a recognition, and it's difficult. The ramping has been an issue, but if you read the rest of his comment, he in fact is complimentary that you obviously were charged apparently back in 2016 in a previous role to, dare I say, take the bull by the horns and try and tackle this. And the evidence from Mr. Hayes was that, I'm paraphrasing him, but some improvement was actually manifested and seen. There seemed to be some progress actually made. So I guess my question is, I mean, that's a demonstration, and this was his implication from his further comments, that we're able to make inroads into this and to see it in its full continuity. Obviously, the focus on the emergency departments, but obviously the ambulances not being able to bring people into the emergency department, so they're, as we say, vernacularly ramped. And then obviously there's the bed block access, not being in. So it seemed that back then there was something able to be done, whatever was brought to bear. I'm just wondering, because I'm actually quite interested, what were you able to do to help tackle the Metropolitan?
Well, thank you, Mr. Donnelly, and I appreciate those comments. It was actually 2015.
2015, okay.
So it was a year earlier that I was asked. I was formerly the Chief Nursing Midwifery Officer for New South Wales prior to being Deputy Secretary, and I was asked to assist with a situation that had evolved during that time where we were seeing some extended delays for ambulance patients being able to be offloaded in our emergency departments, and indeed it had been a problem in the state for probably well before that time. It had been coming for a while, I guess, is the point. And back in the late 2000s, I was a director of operations at one of the local health districts, area health services, and certainly we were experiencing challenges then. So in 2015, we had a well-documented case of a lady who'd waited for several hours for an ambulance to come. And I guess it was the culmination of, as I've said, a number of years of challenges, although, these things ebb and flow with seasons and the like. We found that as a system to be unacceptable, and we took very strong action. Now, the performance that we managed to achieve has been sustained and was sustained at that time for years. It wasn't a flash in the pan effort. It was an effort for us as a whole of system. This is a complex issue, and I need to be clear about that. Health system flow is complex. It's not simple and it's not transactional. It involves so many different balancing items. But the most important balancing item for us was that we had to balance the occupancy of our hospitals against an ambulance service that needed to be able to respond to 000 jobs. And with the permission of that lady's family, we used her story to talk to our staff about what we think is acceptable and not acceptable in our system. So yes, we have KPIs and we have measures for all sorts of things, but actually that is something that we've never focused on here, because that should be the end product, not the starting point. And what we did, to be honest with you, on one level was quite straightforward, and that was that at a Ministry of Health level, we took a very serious interest in this day and night, 7 days a week, and we've done that ever since 2015. That focus has never, ever stopped. So we have people 24/7 monitoring this across our system and working very closely with the ambulance service. But the main balancing item for us was to make sure, as I said, that ambulance paramedics could respond to jobs and not be caught and delayed in our emergency departments. Now, I'm not saying that we don't have delays and that we don't have issues. We do. We're like every other health system in the country and, in fact, the world. We are challenged by these issues. But we commenced by having teleconferences with chief executives 7 days a week across the metropolitan area, but those teleconferences also included the ambulance service and non-emergency patient transport service, to bring us all together to work out where we may have issues and what we could do collectively to resolve them. We also have excellent data sets, and look, as you know, and I think I've said in this in these committees before, I am a health professional, and my fundamental being and the reason I come to work every day is for patients. And what we wanted to focus on was how we could make this better for patients, and we did make it better. We also had a phenomena called ambulance release teams that had been put in the state some years prior to that. I think they'd been in place for about 10 years by that stage, so probably from about 2005-06, which were designed to basically relieve paramedics to get back out on the road. But really all they were was a band-aid to an underlying issue. Because of the work that we did as a system, I was able to remove that phenomena in March or April of 2016, and we have never even looked like replacing it. The one thing I will, if I may, say is that despite the challenges that we have as a health system, and I do want to acknowledge that we do have challenges, we are regarded as the best health system in the country, and we are one of the best health systems in the world. We have had a number of other states and other jurisdictions come to visit with us, even this week, to understand from us how we manage the way we do. Because despite the issues that COVID has presented, and of course furloughing of staff and flu this year and various other things, we have still managed to achieve results for our patients that are better than everywhere else.
But forgive me, but perhaps I was not as clear as I could have been, that Mr Hayes noted and in his own way complimentary about the fact that there had been that kick up, that improvement, called 2015, 2016, but, and prepared to put that he's a straight shooter. But equally, very clearly makes the point that there's been a deterioration, quite a significant deterioration, and this is pre-COVID as well. So it's not just a matter of commencing in 2020, that there was an improvement in things as he sees it, but then that was relatively short-lived. My words, not his. So it seemed to be improved for a couple of years, or maybe a couple and a half years, but there has been deterioration ever since.
Well, Mr Donnelly, certainly the submission that New South Wales Health has made to this inquiry will tell you pretty plainly that it wasn't sustained for a couple of years or a couple of half years. That performance uplift from August or September of 2015 was sustained really right the way through until 2019. So probably about 4 years where we really had, other than the winter periods, 2000.
No, we understand the cyclical nature. So, you're saying it's 2019.
So in 2019, what we started to see, and if you look at our submission, you'll see that you see a direct correlation between an increase in emergency department presentations and a slight decrease, but not a terrible decrease, a slight decrease in performance. So the two go together. What you can then see from our submission very clearly is that when COVID commenced, and I'm not attributing all of this to COVID, by the way, the health system has continued to manage this over a number of years, but COVID has had a direct impact.
No, there's no contest over that, and we're not cavilling with that particular
because
point.
I guess one other thing I would say is that if you remember, and it feels like a lifetime ago, but if you remember back to 2020 when we had the first very significant lockdown of the state, our emergency department attendances reduced very significantly, so down by about 30% during that period, and our performance correspondingly went, very significantly up. So there's obviously a direct correlation between those issues.
We're talking about, and perhaps I need to move on because we obviously probably do agree to disagree in terms of his reflections and the deterioration that he asserts versus the timeline that you've described.
I mean, our data is publicly available, and I think it's...
Well, I mean, it's there, and you presumably, from what you're saying, stand by that. Might move to the Honourable Mark Buttigieg, who's got some questions, and return to myself, and we'll just sort of...
Yeah.
Sure.
Can I just quickly follow up on that from my colleague's line of questioning? So, Secretary, so that 2019 deterioration, which you just touched on, so we had about 4 years of relative success. Was there any systemic change that correlated with that 2019 deterioration in performance, or are you saying the same systems are in place? It's just, it is what it is.
Can I just be clear about the contextualisation of the deterioration in performance?
Yeah.
Because to be very clear, it was we're talking about 5 percentage points.
Right.
Right. So we're not plummeting by 20 or 30%.
Okay.
So the transfer of care indicator is, and this is for transfer of ambulance patients, as I'm sure you've heard, to emergency departments, is 90% within 30 minutes. We, in that winter of 2019, which was again a bit of a challenging winter, it probably looks like it's down at about 85%. But there is also a correlation between that and an increase in emergency department attendances. So I think that's really important to note. Our current performance, which is somewhat lower than that, has absolutely been a direct impact of the COVID pandemic. There is no doubt about that.
So is it the position of the department, because I want to move on to some other testimony here, that allowing for the aberration, and it was one hell of an aberration of COVID, in a systemic sense, things should return to a steady state at somewhat of an acceptable level over the next year or so, because the systems haven't changed, COVID's gone, and everything was okay from 15, 16, and we should continue on that trajectory. Is that the contention?
Look, COVID is still with us, as we know. We've got just under 1,000 COVID patients in hospital at the moment. That's the first time we've been under 1,000 since New Year's Eve. So it's pleasing to see those numbers reducing. Can I just acknowledge, though, that these results cannot be achieved without the hard work of the staff of the New South Wales Health System and the ambulance service. What we are starting to see, pleasingly, are some green shoots of improvement in performance. And just this morning, when I was looking at our transfer of care performance, we're just under the target of 90% to date. Now, we haven't been seeing that sort of performance for quite a while. So it's been really pleasing over these last few weeks to start to see that lifting. We'd like to think that we will be, coming through and starting to see some improvement. The other thing to note, of course, is that furloughed workers, the number of furloughed workers has reduced very substantially. So we're talking about a few hundred now this week compared to at its peak back in January of 6,000 furloughed staff in one day. And that's, in addition to normal sick leave and other leave arrangements. So there are things that are starting to shift in the system that we hope will give our staff some relief from the unrelenting pressure of the pandemic that we've experienced over these last few years.
Okay. So, I mean, clearly this is, well, not clearly, I'm taking it that this is the sort of picture that the Minister's getting, because we heard on evidence on Wednesday, and these are sort of emblematic examples, but they're not, I don't think they're anecdotal. I think, if you talk to enough people, you get quite consistent evidence to this effect. And this was Mr. James Tadros on Wednesday, and I'm reading from Hansard. I will start off with what I've said. I've spent hours trying to sort out an 88-year-old lady in kidney failure who has been waiting 6 hours. I had to go out to the waiting room to pick her up in a wheelchair. I found her laying down across 3 chairs, and some bystanders were helping her daughter to slowly move her around because she was so weak. This is basically third world, and I think the Minister's response was, well, that's ridiculous. And then you go to a nurse on the same day, the testimony, Kelly Falconer, who says, and I'm just going to selectively quote here because it's quite lengthy, "Never in my 25 years have I felt as unsafe in my career as I do now. The past few years have proven to break many experienced nurses. We were already at breaking point prior to COVID, and COVID has just exacerbated this. We were already at breaking point prior to COVID. They are leaving the profession due to many reasons, but mainly because of increasingly unsafe workloads." And on questioning this morning, I think the response I had from ASMOF was that there were very, very limited, if any, fatigue management policies in place. So what's the response to those anecdotes? And as I say, I think they're not just one-off anecdotes. If you talk to enough people, this would be quite a common experience. Because the minister was quite dismissive of it in response in the media the other day, which is somewhat of a concern, I think.
The first thing I would say is for any patient who doesn't get the care that we would like them to have, we can only ever unreservedly apologise for that. It is absolutely the last thing we want for people not to have a good experience when they come to our hospitals. In terms of our staff, I think we've certainly acknowledged before, and I have publicly on many occasions acknowledged the pressure that the staff of the New South Wales health system have been under. I'm not attributing that entirely to COVID, but clearly the pandemic has exacerbated those issues for our staff, and in particular some of our very busy hospitals. We want our staff to be well supported and cared for, absolutely, no question of it. Fatigue management has been incredibly difficult, and it's something we're actively talking to our chief executives about all of the time, because people need to be able to get off and have leave. And that has been very difficult, obviously, as I said, when you've had 6,000 staff furloughed at one time, and people working really hard to keep our health system going the way it has. So it is thanks to them. Look, can I say, this is the same state health system that managed through a pandemic in a way that many others weren't able to. That is thanks to our staff and the efforts that they put in. Now, we've been fortunate to have some investment in workforce this year, of course, and we're very keen to make sure staff are given leave as soon as absolutely possible. So we're very busily recruiting. I'm pleased to say that this so far, since the 1st of July, our active ads for jobs are up by about 20%, and against the same time last year. So that's good to see, because it's very important that we get people into our workforce as quickly as we possibly can. We've got a very good number of newly graduated registered nurses and midwives starting in 2023. I think it'll be our highest year ever. So around 3,700 newly graduated nurses and midwives, and the pipeline is really strong there, which is great. But it's very important that we support those less experienced staff, and to do that, we need to support our more experienced staff. So, you know, we are focused on that.
Can I just quickly jump in? Excuse me, I remark, but if you take, for example, the point you're just making, but then look at Blacktown Hospital, and since December 2021, approximately 20 experienced emergency department nurses have gone. They're gone. They've left. And this is a theme we're hearing time and time again, and the honourable member's example from the very experienced nurse from Northern New South Wales the same. They're just leaving. They're at the point of not approaching the breaking point, that they're broken, they're leaving. So appreciate the point you're making about the advertising and all of that, that's very good, but this is happening in real time now. These people are hitting the wall now. What's being done to deal with it now? I mean, I appreciate, there's all sorts of challenges, but these people are bleeding out of the system. Experienced people.
Well, look, Mr. Donnelly, I think Mr. Minns gave evidence at the estimates hearing around the range of workforce measures that have been put in place. And look, I'm not saying that this has, it takes time for those things to take effect. And I do appreciate that for some staff, they have felt that, they want to do something different. I think that's a phenomena that has been experienced not just in New South Wales, but it's a worldwide issue with health staff. I mean, we see a report yesterday around skills shortages. Registered nurses are at the top of that list. This, again, is not peculiar to this state. What we are trying to do, as I've said, is to invest money so that people can get off and take leave and be replaced with additional staff, because I think that's important. Clearly, we've got to recruit for those staff. We're out there doing that. There is no shortage of effort to recruit people.
Sorry, not to cut you off, but they don't want to change. They actually use words like they love their work. They treat it as a vocation. They would rather do nothing else but do this work. But they have literally hit the brick wall. They want to leave. They would love to stay, but it's just beyond human coping?
Well, Mr. Donnelly, we still have a very, very large health workforce. I mean, I think that ought to be noticed as well. And for anybody who's made that decision, you know, we obviously encourage them to come back to us. We're doing every conceivable thing to improve what we have available for our staff in our workplaces. I just can't state that strongly enough.
Well, can I just say to you again, you know, Prince of Wales Hospital, 32 emergency department staff have resigned this year. I mean, that's quite a cohort of lost, experienced emergency department staff from one obviously large and very important facility, one hospital.
Well, Mr. Donnelly, without knowing what the usual rate of attrition from that department is, it's hard for me to comment. I mean, the workforce in health is not static. People do come and go. But as I say, we are aware of the phenomena, and the COVID pandemic has certainly exacerbated how people feel about their work and wanting to continue to do it, at least for now. What we can do going forward, though, is to continue to recruit. What we've got to do for our health system, and this is not about painting a rosier picture or to sugarcoat anything, but we have also got to be cognizant that if we want people to come and join our health system and we keep talking about how terrible it is, that makes life quite difficult. We want people to come and work in the New South Wales health system because it is the best health system in the country, if not the world, and we do genuinely believe that. Is it perfect? No, it's not. But we are actively recruiting for staff. As I said, the number of new graduate nurses that have applied for jobs in New South Wales next year probably exceeds even what we thought we would get. There are people wanting to come and work for us. We've got to make sure they're adequately supported. That's our job, and that's what we intend to do.
Let me put it another way. I mean, can you tell the inquiry this afternoon what, and I'll just use this figure, I'll pull it out there, literally, so to speak. What are the three most important initiatives right here, right now, in place by New South Wales Health to deal with this extraordinary challenge we have in our emergency departments?
Well, look, I think, again, to be clear, and I've heard your question about the three most important initiatives. I think emergency departments, and one of the things that New South Wales has successfully done over the years, we treat it as a whole of hospital. Our emergency department staff face a lot. They have limited control about what comes through the doors of an emergency department, whether walking through or by ambulance. We focus on our whole hospital because our emergency department staff need to understand clearly from us that this is not all resting on their shoulders. So the critical issue for us, as I said, funding to help support the workforce, attraction, recruitment, retention. So, you know, we've got funding to enable us to attract and retain people in hard-to-fill roles that we've been working through and identifying with our local health districts, the recruitment of the additional staff, but very importantly, the support of the staff that we have got. And that just cannot be understated. There are also efforts underway as to how we can support staff in rural communities who are, you know, we need to be able to recruit all manner of staff into the health system, and we need to make sure they're adequately supported.
Ms. Pez, let me make it easy then. Let's go from three. Can you tell me and tell the committee this afternoon two initiatives specifically in place by New South Wales Health to deal with this extraordinarily problematic situation we have with our emergency departments?
I think I just answered that question, Mr. Donnelly. I've talked about the initiatives that we've got additional funding to recruit thousands of extra staff. We're doing that. So that's one. We've got, obviously, the ambulance service has got initiatives with regard to its paramedic workforce, which are another very important component. And the second issue I spoke to you about was the attraction, recruitment and retention package to attract health professionals into areas that have been traditionally hard to fill. This is not just about emergency departments. They do not sit in isolation to the rest of the hospital.
I think it's fair to say this committee is acutely aware of that reality.
Could I just explore something, Secretary, in terms of the department's awareness of, I suppose, to put it in crude terms, bang for buck? So my understanding is that about a third of the state budget is directed towards health. And then we heard this morning on evidence that, and we've seen in the submissions, 55% of health is contributed to by the federal government, NDIS, aged care, and then 45% to the state. So has there been any comparison, jurisdictional comparisons of the amount of percentages of budgets that get spent on the New South Wales system compared to elsewhere? Because it seems to me like if you've got such a large proportion of budget dedicated to one sector, and rightly so, health is the most important thing we've got, then are we getting value for money compared to other jurisdictions? So, for example, you made the statement that you thought we were world leading. Is there comparisons in terms of what we're getting for our money? So is a third of the budget unusually high for a jurisdictional comparison, or is it acceptable standard, or do we have any analysis on that?
We do. I don't have it in front of me right now, but we certainly do, and we could provide you on notice some more specific information than what I'm about to say. But certainly we have had data historically that compares Australia and New South Wales, in fact, to other jurisdictions, so outside of the country. So as a percentage of spending, the Australian health system tends to hold up very well and have better outcomes. So if you compare us, for example, to the US, they spend far more on health and have poorer outcomes.
Far more, not in absolute terms, in presumably on percentage of budget.
Very significantly.
I mean, that might not be a great threshold comparison. The
Maybe
US,
not, but we hold up even.
What about Northern Europe?
Even if you compare us to, so countries like Norway and Denmark perform very well, they're very efficient and have very good health outcomes. And Australia is right up there with those countries. The UK, I think it's fair to say, even compared to them, they have different arrangements around primary care, which I think is another important part of this whole situation, but we do stand up very well. So I think in response to your question, it's not unusual to have a large amount of public spending on a health system, but we, in terms of bang for buck, as you've put it, we perform very well and have very good outcomes.
So I note that the Secretary of the HSU, Mr Hayes, is calling for a Royal Commission into to address issues like that. As to it, do you think it, given what you've just said, is that, do you think there's validity in that? There would be merit?
Look, it's really for Mr Hayes to comment about his desire to have a Royal Commission into health spending. I know that he's been quite vocal about that. And I understand that he's looking at that and talking to various people.
Can I ask you, in terms of the NDIS and aged care patients taking up beds, do we have any stats on the percentage of that?
Yes, and I think I also gave evidence on this at our recent estimates hearing. I think it's fair to say we're working closely with the Commonwealth on both of those issues, and we're starting to have some more productive discussions, which is really good. The last figures that I saw, we have around 1,000 NDIS and or aged care patient type in our hospitals across the state. Of that number, there were just over 600 who were beyond their expected date of discharge. So that's quite a significant number of people occupying hospital beds. But it's our job to care for them, and I think that, to be clear, I don't want that to be, read as we're denigrating those people or being disrespectful or uncaring. It's just that they've been medically cleared for discharge and we're unable to discharge them. So there are various groups that are meeting at a state and Commonwealth level to talk about that very issue, and the Commonwealth Government has been quite vocal. Minister Shorten attended a health ministers meeting not long ago to talk very clearly about the improvements that he would like to see in the NDIS, and we're very encouraged by that. And certainly we're having very active discussions with the Commonwealth about primary care.
Deputy Chair, Hurst.
Thank you. Thanks, Chair. I might go back to, I know the Chair was asking questions before around recruitment, and Ms Pearce, you were talking about the recruitment efforts that are currently underway. I know that the government's investment was fairly recent, only in June, to recruit another over 10,000 full-time staff. But I'm wondering if you're able to give an update on how that recruitment is actually going and if there's a time frame around those roles.
Look, I mean, obviously we have, and I'll need to refer you back to the comments that Mr Minns made at the estimates hearing. Certainly he was able to go into quite a bit of detail around those. The time frame for us in this financial year, 22-23, is of that 10,000 number, there were just under 7,700 staff within that number, and so there was funding to support that. As I said, the information that I've been provided is that as it, I'm not sure if it's the end of August or September, we're 20% up on our advertising efforts compared to the same time last year, which is an important, so that's requisitions that have gone into the system to recruit to roles. And so obviously that additional funding is supporting that. I'm not sure if Dr Morgan's able to comment about the paramedic enhancements, because that was quite a large proportion of that number as well.
Thank you, Secretary. Yes, so ambulance was provided funding for 2,128 additional staff over the next 4 years. During the pandemic, we had recruited already 338 additional people that this provided funding for us to maintain. So those 338 are already on the books. And since the 1st of July, we've put on another 292. Only in the last couple of weeks, we've just closed graduate recruitment for those paramedics who will be graduating university by the end of the year. And we've had more than 840 applications from those people. So we're in a very good spot in terms of meeting our targets.
Thank you. And just sort of following on from that, Ms Pearce, you mentioned, there was an increase in advertising, and Dr Morgan was able to sort of give quite a specific number of applicants. And I guess some of the evidence that we've heard in this inquiry is that it's just so difficult to fill some of those senior roles, like once people have left. With that sort of increase in advertising, are you still sort of seeing that increase in advertising is able to actually recruit some of those senior roles, particularly in some of these hospitals where we're hearing that it's even more difficult, such as Western Sydney and other places like that? Are we seeing an outcome from those increase in advertisements?
Yeah, look, I think to the point of your question, Ms Hurst, is if we're attracting more experienced staff, I'd have to take that on notice in terms of the years of experience, if you like, if that's possible. Look, the one thing I would say about that, though, which is an important thing to note, we do see more experienced staff retire or resign, in normal circumstances, let alone the circumstance that our staff have endured over these years. When I was the Chief Nursing and Midwifery Officer, one of the things that I needed to work really closely with the system about was we just need to be careful about how we characterise the recruitment of staff, because the issue is that sometimes we keep trying to recruit more experienced staff and they're just not there. And that's not that's not a failing, it's just a fact. We have a lot of really excellent, less experienced staff that we recruit every year. Our job is to then support them into the workplace, and so that's really important that we look at it in that way. We've invested over the years, and I think in the last 10 years we've increased our clinical nurse educators by about 50%. So there's been a significant increase in clinical nurse educators to support less experienced staff. So when I talk about, there are parts of the health system you talk about, none of it, there's always a knock-on effect in other areas. And one of the clear issues for me, as I said, when I was, and I'm going back a few years now, really was that we needed to stop just focusing on trying to recruit more experienced staff if they weren't there, recruit perhaps some less experienced staff, but make sure that they were adequately supported in the workplace.
Thank you. And I guess and this kind of fits in with your answer as well. Obviously there's the recruitment issues, but one thing that came up a lot was, the strategies that need to be worked on to support workers and improve their working conditions so that we retain workers or even re-attract people who have, and this kind of flows on to some of the questions that the Chair asked as well, where people are wanting to work in this space, but they have, burnt out. And how do we regain those people back in? Is there strategies being deployed by New South Wales Health specifically for that retention, improvement of workplace, and even getting experienced people who have left that haven't necessarily retired, but helping them get back into the system?
Yeah, so look, one of the things that we were able to continue to do during the course of the pandemic, and we'd started it prior to, was to, and you may be aware, we've been very focused on patient experience here in New South Wales for a long time, and to improve that, you need to improve the experience of staff. We have a Chief Experience Officer, Dr. Anne-Marie Hadley, who has been working with us now for quite a few years, and one of the pieces of work that she was able to complete during the pandemic has been the Elevating the Human Experience Guide to Action. Now, it was important for us. We've got a lot of engagement with staff around that, and people who are invested. Simple things like kindness works here because it's important for us to get the people who come to work every day with that attitude, to encourage more people to come to work every day with that attitude, and I think the great majority of our staff do. So that's just one example of the work that we've done, because we absolutely do recognise, as I said, that if you're going to improve how patients feel about the care they've received, you've really got to improve that for staff. This is, as I say, in addition to the investment to try and recruit more staff, to allow people to go and take a well-deserved break. I don't think we can underestimate the impact of not having proper leave has had on staff in health systems, in all jurisdictions, and on all of us who have worked now for a very long time with very limited periods of leave. It's certainly not something that we want to see to continue, so it's important that we arrest that trend very quickly.
Yeah, on that point, and I note that in the submission it said that there's a plan to decrease employee excessive leave balances. Does that mean that employers will be forced into annual leave? How is that going to work in practice?
Look, there are already arrangements in place with regard to annual leave. When you get to a certain point where you've accrued too much annual leave, that's relevant to all public sector workers and probably in other industries as well. And again, it's not particular to New South Wales. But it's been difficult for people to take leave, obviously, during these circumstances. To be able to give people the opportunity to take leave, you've got to recruit more staff. That's a simple fact. The other thing, though, that I think, and I don't mean to dwell on this, but that furlough number was a very, very significant impact on our system, because it then led to people needing to do overtime, and so that cumulative effect of, not taking as much leave as you would normally, working overtime, clearly has had an impact. So it's very important that now, as that furlough number comes down, that people are given the opportunity to take leave. We have seen some reduction in emergency department attendances over this probably last 3 to 4 weeks. So we're starting to see a little bit of a softening there, which is good to see, and that's important. And as I say, you can see then a correlation in the fact that performance then tends to rebound somewhat as a consequence of that.
So are we it almost sounds like there's a reliance on two things, and that's that the presentation at emergency departments, that trend will continue to go down, and that recruitment will continue to go up. But, as we've heard, there's so many things and outside factors that we can't control, particularly with how many people are presenting in emergency departments. If that trend doesn't happen, are there any concrete plans to reduce the overtime or to allow staff to take that leave, or is it reliant entirely on that recruitment, and B, a hope that that there'll be less presentations?
Oh, look, I certainly wouldn't reduce it to two factors at all. I think, as I said, the reduction in 6,000 people at one time, even in a system of our size, is a lot of people. That would be, and sick leave, of course, was also impacted because people, it wasn't just COVID related. We had a pretty significant flu season this year as well. So that will assist. None of this is just straightforward or simple or on its own. There's a whole lot of other stuff that we could talk about, and again, it's in our submission with regard to the work that we're doing to ensure that the people who come to our emergency department are in the right place. We've said many times, publicly and in these forums, that the people who are the most unwell, our job is to treat them as quickly as we can. Sometimes that means that people who are less unwell or in lower triage categories wait longer. That is the nature of emergency. And it's the nature of how our emergency departments will always operate. So I think that there is a stack of work going on to reduce emergency department reliance and demand. Again, we can point to examples within the ambulance service, with our virtual care centre that we established, unfortunately, prior in particular to the Omicron wave. We've done a lot of work over the years, not just actually during the COVID pandemic, but, to make sure that we identify people with chronic disease, so that we can give them the best care. We've got virtual hospitals, so the RPA virtual that we established again, fortunately, just prior to the pandemic, has been one example of a way that we can treat people safely and carefully in a different way. It also gives our staff an opportunity to do something different. And I think that's an important thing for us to think about as well. Look, I've been in the health system, like many of my colleagues, for a long time. What is clear to me in this environment is that if we keep trying to replicate things that we've historically done, it just will not work. We have got to try new ways of doing things and new models. We're very focused on that. The younger generation is demanding different things of their workplaces. That is clear. And I think it's more starkly clear now than it has ever been. Younger people are not going to work and do, they've got a much better focus on work-life balance, and I say good for them. But we've got to move with the times and start to think about how we adjust our thinking in that way as well.
Just moving on, because I've only got a couple of minutes left, but one of the key areas of concern that really came up in this inquiry was around patients seeking help that have mental health issues that end up in an emergency department, and then for them having to deal with long waiting times. It's a very difficult environment, obviously, in an emergency department. And it was suggested that, we need more alternative out-of-hours care, specifically around mental health. Is New South Wales Health doing any work in this space, like investments in programs or trials that will help alleviate that issue?
Yes. Look, I couldn't agree more about alternates to emergency departments for people with mental health issues. Really, they are not great environments for mental health. But of course, there are circumstances where people, absolutely, that's the right place for them to be. So there is quite a significant amount of investment in alternates, and one of those is, and I think, again, I don't mean to continue to reflect back on estimates, but it was pretty recent, was the safe haven models. We have 15 of those. There's been, an investment of around $90 million in those. There's further 5 to come. We're seeing some positive results from those as an alternate to emergency departments. We did establish some years ago now the PACER model, which you may have also heard about, between ambulance, police and our mental health services. We've continued to expand those models. But look, again, the and going back to, you know, the sort of last report that I can put my hands on in terms of how we compare to other states on this measure, New South Wales emergency departments have the highest proportion of mental health patients seen on time within triage categories compared to other states. So, you know, and it's something that we've also worked with our clinicians on. We've got some fantastic models in our emergency department.
Can I just, I'll just throw this quickly, just because it was one question, one issue that came up, was whether there was money going into, and a brief answer would be appreciated, but one young person came in and said that they weren't even aware of what any of these services were. Is there any money going into, advertising for those services so that when people need to find them, that they can?
Yeah, look, I think we can always do more on that. I think it's very important for us to make sure that all of our services are, people know where they are, and we are certainly over the last couple of years in particular, we've improved how we communicate even via social media. So yes, but I'm happy to take that on notice and think about what more we could do.
Thank you.
Thank you, Chair. Can I just check, we've clearly got bigger, larger time slots this time. Is that right?
Yes, half an hour, 15.
Okay, thanks. So, okay, that makes sense. Okay. I'm not going to. Thank you. Ms Pearce, in March budget estimates, I think you were sitting beside the Minister when he was asked by me about the ambulance ramping at Westmead Hospital, and he said at that time that the concept of what still causes major grief in other states, that is ambulance block, is actually very rare now in New South Wales. Did you advise him after that budget estimates hearing that in fact what he said was grossly incorrect?
No, I don't recall having that conversation, no.
So when you were sitting next to the Minister and he said to me in response to a question about ambulance ramping and how it was taking place at so many hospitals right across New South Wales, particularly in this situation, southwest Sydney, and he said to me the concept is actually very rare now in New South Wales, you didn't say to him afterwards, Minister, it's not very rare in New South Wales. What you said in that budget estimates was actually incorrect?
Look, what we have always said, is that our system is not perfect and we have some very difficult days. We are clear publicly about that. We're clear with the Minister about that. My recollection of the comment was in the context, as you've said, of other states.
No, I didn't say that. No, sorry.
I'm talking about my recollection. I thought you said he said about other states. Didn't you?
No. So what he has said on the record and on Hansard was that the concept of what still causes major grief in other states, that is ambulance ramping, is actually very rare now in New South Wales. Basically, ambulance ramping is very rare in New South Wales. So is that correct, firstly? For March 2022, was that correct? Was ambulance ramping very rare in New South Wales in March 2022? Or now?
We have, look, so can we separate, the Minister's comments are on the record.
What it goes down to as well, though, Ms Pearce, is what the department and what you are advising the Minister as to what is actually going on in our hospitals, in our health system. If he is coming to budget estimates and seems to be implying that everything is fine, when we are hearing witness after witness during this inquiry basically telling us how much of a crisis our hospitals are in, the question has to be asked, is the Minister getting the right information, or is he deliberately misleading both this committee and the public about just how bad things are?
Our information around our performance has been publicly reported in this state for more than a decade. So our advice to government is always straightforward because we publicly report our information.
So when we have witnesses just 2 days ago who are doctors, who are senior specialists, emergency specialists working in Western Sydney hospitals who say this is basically third world. What's your response to that?
I think we've touched on this already, and what I say to that is that it's not for me to come here and contradict the staff of the health system that they've explained that's their experience. I don't agree with it. New South Wales Health is not a third world health system. It resembles nothing like a third world health system, and I stand by that. Our performance, our relative performance around the delay of ambulance patients being transferred to our emergency departments is challenged at times. Do we have the same challenges as other states and the depth of the challenge of other states? No, we do not. And our submission provides publicly available information that goes to that very point. The last data that was provided, and it's in our submission.
That's okay. If it's in your submission, I'll just leave it there because I've got limited
I'd like
time.
an opportunity to, I guess, essentially reject the comment that you have levelled at me that I'm providing inaccurate information to government.
No, the question was, did you correct the minister when he said it was very rare? And I was just asking that.
I have provided an answer to that in the sense that we provide publicly available data on our performance.
I just want to go back to previous, again, evidence by health senior specialists working in our public hospital system, particularly in southwest Sydney, who gave the example, the extraordinary example of, and I said it's a common example, that the College of Emergency Medicine frequently asks about situations where there's a surge or there's a disaster that needs to be dealt with. So basically the question is answered on the basis of a hospital having a normal 80% or 85% capacity, right? But what he has said is they don't know how to answer the question. They don't know how to approach the question. These are young doctors now working in the system because every situation is always a disaster. He said there have been situations where people have been confused by the question because the question alludes to a disaster and they're expected to identify that, but that for them is what they're doing every single day. And it just seems that there's this disconnect between what New South Wales Health is telling us, what the minister keeps telling us, and what every single witness to this inquiry is telling us, particularly those who are working on the front line in our hospitals. It's a disaster every single day, doesn't correlate with what you've just told this inquiry, that this is basically one of the best, we've got the best health system potentially in the world. What is going on here?
Today as well.
What is going on here?
Look, I think the first thing to say is that I don't believe that there's a disconnect between New South Wales Health and the system. I mean, I've been very open and direct about the fact that our staff have been under enormous challenge. I've said that today. I've said it publicly.
They keep saying the public health system's broken.
Well,
That's pretty much what most witnesses
I don't agree that
say
that's what
straight up.
All of the witnesses to this inquiry have said, because I've heard some of the testimony that's been given, and I've also heard a number of them say the efforts and the engagement with New South Wales Health is strong. We are not disconnected from our system. We know that there are days which are incredibly difficult. I do not support the comment, from my perspective, looking at the system, that every day is a disaster.
Okay, can I ask then why, if that's the case, you have put in submissions, as I understand it, to the government, and this was revealed in a recent edition of the Saturday paper by journalist Rick Morton, that New South Wales Health has put in applications for funding that have been rejected by the New South Wales government. I understand it was requesting a net cost of service increase of $510 million. In that, you said it's critical that the annualisation impact of these new facilities are recognised to meet the ongoing service delivery and operational demands from the community. So it's that in other words, New South Wales Health is asking the government for more money. That continues to, the government is building all these new hospitals internally within New South Wales Health. You're lobbying them for more money to meet operational requirements, aren't you? And they're not giving it to you.
Well, the first thing I would say, I think from memory, and I'm sorry I don't have that article, but I'm aware of it, was, and I can't remember what year it
So
was.
the increase, yeah. So it says basically this article, which was a GIPA document, increase in activity cannot be accommodated within the existing funding envelope because they're opening all these hospitals, but there's clearly there's not enough money within New South Wales Health, is there, to accommodate the demand?
We had a 10% increase in our budget this year. So that is a very sizable increase, just given the fact that we've already talked about the quantum of the New South Wales Health budget. It has gone up substantially over the years, and in fact, if you look back, and I've got the figures, we've had an increase of around $8 billion in the last 10 years.
Yeah.
And don't forget the money that we've had to manage the COVID pandemic.
Can I check with
I think
the increase in funding? Just a question though, because so again, a lot of witnesses, particularly the doctors and the nurses and the unions and the Australasian College of Emergency Medicine were telling us that we really need beds, right? We really need beds. It's kind of access block. There's not enough beds. Why is it, I've got data here that suggests that Westmead Hospital in 1997 had 900 beds and it's got 553 now. Why? But that's extraordinary. Like the population in 1997 was 6 million, just over 6 million. Now it's just over 8 million. We're reducing all of these beds around New South Wales. That's a broken system, isn't it? There's just not enough beds.
It is not a broken system, and can I tell you that we've just talked about the capital program, which has been significant across this state.
Why is there such a reduction in beds? It's a legitimate question. Why are we reducing beds over decades?
Well, let her answer.
Well, I don't have...
I'm not sure she was going to.
I don't have the bed numbers for Westmead that you've pointed out for that period. What I can tell you is that for example, the 11-12 budget for Western Sydney was $1.3 billion. It's now $2.1 billion for this year. Models of care have changed substantially over time. People's length of stay in hospital has reduced. We've changed the way we operate compared to what it was like when I was nursing some years ago, and that's how health systems of the future will need to continue to look. But there is this proposition that increasing beds will cure this issue.
Ms. Pearce, I think the question is more like, is decreasing beds, has that led to the crisis facing our hospitals now? Like, talking about different models of care, and you're sure, we hopefully do better as we progress through the years. But what we heard on Wednesday from nurses and doctors was a horror show. It was a horror show of people waiting in corridors, people who couldn't, elderly women who couldn't be examined in corridors, like with dignity, people who were dying. This is what we heard, and I'm asking you, why are we why do we have such a reduction in beds? Everybody has said how many beds we have had in the 70s, in the 80s, in the 90s. So when you were also talking about solutions, when Greg Donnelly asked you about solutions, you didn't mention additional beds.
No.
So that's not on the government's radar?
So can I just answer the question?
About the beds?
Yes.
Yep.
If I can't agree to what you're saying in terms of the numbers because I don't have them in front of me. But if what you're saying is correct, the performance of the health system in the, as I've said earlier, in the 2000s, even in, early 2010, 11, 12, was not as good as it is now. And it certainly wasn't. So in 2015, when we made the changes that we made, it wasn't just about ambulance transfer of care. Our surgery performance is excellent. We actually, so the performance of the hospital system is better than those years that you refer to.
So with all of because just the evidence that we heard on Wednesday again.
You also have evidence on transcript from us that is not being referred to. We've clearly pointed to the performance of the New South Wales health system.
Yes, and I'm giving you evidence from people who are working on the front lines, who are telling us every single day that they arrive at 8 a.m. in the morning. There's like 20 people waiting. One of the doctors that we heard said that it's a common everyday occurrence for 30 to 40 people to be in the emergency department when he arrives at work with 10 to 15 people waiting for beds.
So we've talked about some of the factors that impact our hospitals. The hospital system doesn't exist in and of itself on its own. It is impacted by so many other factors. So we've talked a little bit about the aged care and the NDIS and the number of patients that we have. We've talked about COVID. Even though we're below 1,000 COVID patients, we didn't have that phenomena in our hospitals before. We haven't talked about primary care and the challenges between the primary care system and the hospital system that desperately need to be discussed.
So one of the things, because I've got 5 seconds left, and I'm just going to try and squeeze one more question in.
I haven't been able to give you an answer.
Well, I just feel like the answers are situation normal. The answers are a little bit like everything is fine. And what we also heard was what New South Wales Health is doing right now isn't enough, that it's kind of band-aids, if you like, on a system that is collapsing, that, senior nurses, senior physicians are retiring and moving interstate. And it sounds like the government isn't really acknowledging how bad it is, and therefore the solutions can't come if the acknowledgement isn't there of how much a crisis we're in.
First thing I will say to you is I am not the government. I'm a health professional working in the New South Wales health system. I absolutely acknowledge the pressure the system's under. I've said that repeatedly this afternoon. I am not disconnected from the New South Wales health system. I've worked in it almost my entire working life. We have got incredible staff who have worked under the most difficult of circumstances. We are doing everything conceivable to improve our workplaces for them, and that includes working with the Commonwealth, with primary care, to think about how we can find better places for patients to get care that don't need to come to an emergency department, to manage the surgery backlog that we've got as a consequence of the pandemic and get those people their surgery they need as quickly as we can. None of these things sit in splendid isolation. They're all connected to each other. And they're only possible because of the staff of the New South Wales health system. I cannot state that strongly enough.
Okay, I think that brings us to the end
brings us to the government, yeah.
Yes, to government members now, if they have any questions that they would like to ask or...
Okay. Thank you very much, Ms Pearce, for being here today. And I think you touched upon it, and we've heard it in the inquiry as well, that effectively when it comes to these issues, they're not isolated in issues that are just affecting New South Wales. We've seen the front page of The Australian today, which has the headline about South Australia and about the system failures that they're seeing with the new Labor government in South Australia and the 4 worst months recorded when it comes to their wait times. Can you tell us about, is there anything we can learn from the approaches being taken in other states? Is there anything we're doing differently to New South Wales that we could adopt potentially from other states?
Well, look, as I said earlier, we're very pleased to assist other states, actually, and we've had our colleagues from South Australia come to visit us here in New South Wales, also from WA and from Tasmania, and we've offered to assist our colleagues in South Australia by sending some of our team down to have a look and see what we can do to assist them. I think, like us, their staff have experienced a really challenging time, and I guess what the experience there tells you is that there is no simple quick fix to these issues. If there was, we would have done that by now, because we are all invested in improving the experience of our staff and our patients. So we're always looking to learn from other states because, that's how the health system operates. We learn from other countries, we learn from other states. But most commonly, they're coming to us. And that's because our data does speak for itself. And despite the challenges that we have, and I don't underestimate those and I don't diminish them, our performance is strong, and I think it will continue to get stronger as we climb out of this pandemic. I think it's very challenging for us that after what the health system has experienced during the COVID-19 pandemic, that is quickly forgotten. But the impact of it is not forgotten, and it's going to take us some time to get through that, and that's what we're aiming to do.
Ms Pearce, turning to some of that impact from COVID, of course, we've had some discussion today about elective surgery, and of course we know that while urgent elective surgery, critical elective surgery continued, non-urgent elective surgery was paused for some period. Can you perhaps outline some of the measures that New South Wales Health's undertaken to get on top of that elective surgery waiting list as well?
Yeah, look, I might ask Mr Daly to comment if that's okay, because I think I've had my share of talking anyway.
You can have a glass of water now.
Yeah. I guess what we've experienced, courtesy of, once in a 100-year pandemic, is an elective surgery waiting list above our normal expectation that's at the highest that it's been for some time. But having worked in health for 30 years and in this system for most of that 30 years, cyclically this actually happens. I've cut my teeth on reducing elective surgery waiting lists, and having observed the system after the first wave of COVID, where waiting lists above benchmark levels to be treated rose in excess of 10,000. I also saw that was when elective surgery was suspended, as it was earlier this year. But then we also saw the system actually recover that 80% in 12 months. So just on that recent experience, we've got a challenge now. It's publicly available information, about 18,000 cases that are overdue. And we've seen that come down each of the last 3 months between 200 and 500 cases. That's not the level that we're at, because now we're instigating a whole host of formal programs. The LHDs are working very, very hard. It's very clear from government that to the LHDs and to the ministry that this is the priority. Now that we are coming out of COVID, we're re-establishing capacity. We're increasing surgical capacity within our public hospitals. We're networking surgical capacity between hospitals to make use of vacant theatre sessions, models of care. I mean, day-only hip and knee replacements, unheard of back in the 2000s and 90s. Part of a contribution why we don't need as many beds. But that's a multifaceted question. We also have engagement with the private sector to the tune I've not seen in my 30 years in public health services in 2 states of this country, where we're using and partnering with the private health sector for surge capacity, where hospitals within our system can't surge because of furloughing and the like. But now for elective surgery, formal contracts to take on large volumes of this, and having observed this system and worked in it for so long, I'm really confident about us addressing that overdue surgery number that's in front of us now. I think we'll see a dramatic improvement by the end of this financial year.
And that's been backed up by resources, Mr Daly, as well?
Yeah, government has provided funding. It's not at my fingertip, but there is...
408 million.
408 million. I should know that, shouldn't I? As the deputy, I should know that.
So both the resources are there to be able to address this backlog, but as well you're doing things differently to be able to make sure it's a shorter turnaround time.
Like most things in health and elective surgery, there's no one simple solution. It's a whole series and a myriad of steps and strategies all executed to complement each other.
Now, while I think we've heard a lot of different evidence, I'm only sitting on the inquiry today, but while we've heard a lot of different evidence today, it seems to be that everybody agrees at least on one thing, that there's no silver bullet when it comes to addressing these issues. It's a multifactorial issue to address. But one continuing theme has been about system flow, and effectively the challenges with system flow from a whole range of different perspectives, whether it be from the evidence we heard from the pharmacists today or whether it be from surgeons. There's a whole lot of different groups that have a different perspective on their part of the system. I'm just interested in what New South Wales Health is doing to work with all of the different participants in the system, and what are some of the views you have about how you can address system flow?
Yeah, look, I think it's really important that we hear all those perspectives, because that goes to the health of our health system, that staff do have the opportunity to raise new ideas and new concepts. I actually heard or saw the comments from the pharmacists, and I thought, yep, absolutely, that's something we need to look at in our hospitals. I think that's a really important area to focus on. Sometimes there are some little things that you can do that actually make a lot of difference, and they may not seem obvious, so that's important. It's why we've always, or not always, but for certainly the last several years, dealt with our hospitals as a whole of hospital rather than just focusing on one area. So it's important, and then all of those factors that sit around the hospital system are important to think of as well. The way we engage, there are many ways that we engage, and I think we can actually do more of that. And during the pandemic, one of our colleagues, Dr. Nigel Lyons, had established a clinical council, so we were hearing straight from our clinicians to talk to every week or every fortnight, depending on what was happening, about issues and what they were experiencing. So, we've got an agency of clinical innovation that's got thousands of clinicians engaged to provide their ideas and new innovative ways of doing things. I think we can elevate that more in our system. It is really important that people like us who work in departments and the like hear directly from clinicians. But of course, at a local health district level, our chief executives have lots of engagement forums as well. The industrial bodies, the professional colleges, everybody's voice is important in this discussion, and we need that collaboration as we work together to put the pandemic hopefully behind us and think about what does the health system of the future look like.
Thank you, Ms. Pearce. Now, interested as well, Dr. Liz Swinburne this morning provided some insight into the role of virtual care and care in the community as well. I'm just interested in terms of what is New South Wales Health doing in this space to alleviate some of the issues that we're seeing?
Look, I touched on earlier the issue of RPA virtual, so that, again, that's being, we've had lots of visits from other states to come and have a look at that. It's one example, there are many others. But I might get Dr. Morgan to make a comment about the ambulance VCCC, because I think that's been a great addition to the service.
Thank you. Look, I think this whole topic and the understanding of the problem of flow is critical to understanding the impacts of access block. And the fact that flow is easily interrupted at any point along that journey. One of the major things that New South Wales Ambulance can do, obviously, is try and have an impact on the number of people going in and presenting to an emergency department in the first place. And sometimes that is about identifying early what the appropriate alternative disposition for those patients actually is. So if you think about it, people ring 000, the first thing that they're going to be done is triaged as an emergency. Virtual clinical care for us provides an opportunity through a structured call-taking approach to divert some of these calls to another clinician who can take a bit more time to properly analyse whether or not some patients might be better off going into another pathway. I'll give you a really good example around residential aged care facilities. Very commonly, ambulance would be called via 000 to attend a residential aged care facility. Now we actually refer a call that is not identified as immediately life-threatening to a clinician in our virtual clinical care centre. According to a secondary triage where they ask more questions, we've been able to successfully divert more than 2,000 calls since we've had our virtual clinical care set up, with an 85% referral rate. So the patient's either looked after by their own GP, looked after by the local health district team, aged care assessment team, or looked after by the actual aged care facility themselves. So an 85% diversion back to care that is appropriate for their condition rather than to an emergency department is a really good way of actually reducing care. In the 12 months that we've had just the VCCC working, we've managed to deal with more than 13,591 patients that we've been able to divert off to other dispositions. Likewise, we engage with Health Direct, similar sort of pathway. In the last 12 months, we've diverted 67,000 patients to those, of which they've been able to deal with the patient's presenting condition in a way other than sending to an emergency department in more than 52% of cases. So you can see 10,000 here, 10,000 there, 100,000 here, eventually helps to reduce the load of us presenting to any given emergency department, of which we would be, depending on the LHD, 22 to 30% of any load. So it's a significant strategy to ensure people actually get to the right place for the right condition that they have.
Thanks, Dr. Morgan.
I just have one question. So with you did an ED patient survey 2021. Is there one available for 2022 yet? And I only say that because you said they rated their care as very good, which was unchanged from the year before, and also of the percentage of, I guess, people who present, what percentage actually complete the survey?
I'd have to take that on notice. I don't have that information. I'm sorry. Yeah.
Okay.
Is there time? Has Mr. Amato got anything?
Honourable Lou Amato, do you have any questions? Or more specifically, a question? We've got about a minute to go.
Yeah, perhaps one. Pierce, you mentioned earlier about possibly looking into what pharmacists can do. That's something NSW going to look into?
Yes, yeah. I think there's an opportunity there to think about how we can better equip ourselves in that regard in our hospitals. I'm talking about specifically. One of the common issues that creates delays in people being discharged from hospital is waiting for discharge medications. That's just a very simplistic example, but it can be quite impactful. So I think there's an opportunity for us to think about that. As I say, look, we leave no stone unturned. We certainly make every effort to take on board those suggestions, so happy to look at it.
Okay, thank you very much.
Okay, well, I think whilst we probably could go on further, I think we've had a fair go. But can I just, on that point about the pharmacists, just sort of make this observation. I thought the evidence from the pharmacists this morning was very interesting, and I don't make this statement as a criticism, but other witnesses and the ones in particular for lunch about the need to laterally understand this system-wide situation we're in. And I take your comment that in terms of the pharmacist's evidence, it may be not a matter that had been on your radar, but you've heard it for the first time. Not criticising you, one sort of wonders how many other stones are out there that could do with a bit of a flip. But more to the point, how do we get those stones flipped to sort of get them onto the table and discussed so that the full universe can be looked at as far as we practically can, as opposed to obviously dealing with these matters in almost discrete silo discussions. There is a sense of that.
Mr. Donnelly, or are you making it?
I guess I'm giving you a lecture, which I've got no right to.
What I'd like to reinforce with you, though, is the response I gave previously, and that was that we do have an agency for clinical innovation. I think it's important not to leave you with the impression that we do deal with this on a piecemeal basis. We actually have for many years taken a whole of hospital approach to this.
Yes, no, you made that.
And the ACI has been instrumental in that. So it's, look, but what I'm saying is that there are always new ideas and we should be open to considering those. But thank you for the lecture.
On that point, we'll wind up. So thank you all very much. Appreciate coming in and